Well, maybe not prior, but we are practicing by our, okay, back in the latter point. Yeah. Oh my God, you just supposed to take your, it is, the money. But that one you want.
Laura? Laura, are you there?
Anna? Hello, Anna.
How are you? Oh, I know. Thank you. Thank you. Nice to meet you. Yes, yes, yes. Nice to meet you. We got a flight at any night. Oh. Yeah, it's like 3 o'clock. Thank you very much. Yeah, yeah.
On the line.
Hello, Anna.
Laura, there's some feedback. I think you might need to either hang up and call back in.
Okay. Hey, Anna.
That sounds much better.
Okay, good. Thank you. Can you see my slides?
I can see your slides, yes.
Okay, good. And so I'll be able to advance them once the presentation starts.
That's right, yeah, just advance like you normally would.
Okay, excellent. Thank you.
Thanks.
Okay, well, welcome everybody. I want to welcome our guest who's joining us by Zoom, Dr. Laura Banford, and from the Philadelphia 5 Community Health Centers. So before we cede the floor to her, I just want to welcome everybody. My name is Dr. Carlos Del Rio. I'm the Huber Professor and Chair in the Huber Department of Global Health at Rollins School of Public Health, and I'm also Professor of Medicine at Emory University. And I chair this committee examining the integration of opioid and infectious disease prevention efforts in selected programs. I want to welcome our guests in the room and those joining us via the web. This study is sponsored by the Office of HIV/AIDS and Infectious Disease Policy and the Office of the Assistant Secretary of Health in the Department of Health and Human Services. I'm joined by the committee members of the study and by National Academy staff. I will ask them to introduce themselves shortly. Before we go further along, I want to note that this is an open, on-the-record session. Interested individuals have been invited to attend and observers via web conferences. I also would like to remind everyone that this is an information gathering session. That is, the committee is in the process of assembling materials that it will examine and discuss in the course of making its findings, conclusions, and recommendations. Therefore, I ask everyone here today to be extremely mindful of the fact that the committee has made no conclusions and that it would be a mistake for anyone to leave here thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or the academies. In addition, committee members typically ask probing questions in this information gathering sessions, and this will that may not be indicative of their personal views. The committee will deliberate thoroughly before writing its draft report. Moreover, once the draft report is written, it must go through a rigorous review by experts who are not anonymous to the committee, and the committee must then respond to the reviews with appropriate revisions that adequately satisfy the Academy's report review committee and the National Academy of Sciences president before it's considered an official Academy report. I would like to explain the format of our meeting today. We have asked representatives from 4 programs to join us today to discuss their experiences with integrating opioid and infectious disease prevention and treatment services. Thank you for joining us today. We hope to hear about the processes of integration, including factors that facilitate integration, as well as the challenges that make integration difficult. After each presentation, we will have time for discussion with the committee members, and so, as the time allows, we will take questions from those joining via the web. We have attendees interested in asking questions. Please submit your questions to Andrew Merluzzi, and the email address is amerluzzi@nas.edu. Please note that this meeting is being recorded. Now, I'm going to ask the committee members to introduce themselves, give their names and current affiliations, and brief bios of the committee members and speakers are available online or in the attendings package. So please, can we go around and, Julie, can you start?
Good morning. My name is Julie Baldwin. I am the director of the Center for Health Equity Research at Northern Arizona University.
I'm Dr. Edwin Chapman. I'm Chief Medical Officer for the Medical Home Development Group in Washington and also an adjunct assistant professor at Howard University in the Department of Behavioral Health and Psychiatry.
Hannah Cooper. I'm on faculty at Emory University's Rollins School of Public Health.
Hi, I'm Dave Gustafson. I'm from the University of Wisconsin. I'm a systems engineer.
And I'm Holly Hagan. I'm a professor at New York University College of Global Public Health.
I'm Mo Yanamig. I'm not a committee member. I'm from Buffalo, New York.
Andrew Talal, hepatologist, Buffalo, New York. I'm also not a committee member.
Joyce Johnson, not a committee member. I work at Stepworth Recovery Centers in Elizabethtown, Kentucky.
I'm Ellen Eaton. I'm an infectious disease clinician investigator at UAB, and I'm an OMIN fellow with the National Academy.
Dave Thomas. I'm an infectious disease specialist from Johns Hopkins.
Hi, Sandy Springer. I'm an associate professor of medicine at the Yale School of Medicine, section of infectious disease.
Jody Rich, infectious disease and addiction doc at Brown University.
Robin Newhouse, distinguished professor, Indiana University and Dean of Indiana University School of Nursing. I'm a health services researcher and also have an affiliation with PCORI.
Andrew Miluti, I'm an associate program officer at the National Academies.
Rose Martinez, I direct the board on population health and public health practice.
Thank you very much. Thank you for the committee members for being here and for our guests. We're going to start the first presentation. I would like to introduce our first speaker, Dr. Laura Banford. She's joining us via Zoom. Dr. Banford is the medical director of Clínica Bienestar and a staff physician at the Jonathan Lax Treatment Center and a clinical assistant professor of medicine at the University of Pennsylvania Perelman School of Medicine. Dr. Banford, we would like you to, we have approximately 30 minutes and we would like to have you, tell us about your program. So give us a biography of your program in somewhere around 15 to 20 minutes. Tell us about how you got there, and then we'll be asking some questions. If you had anything related to the opioid epidemic, you can skip through it pretty quickly. We want to hear more about your program and less about some of the actual context of the disease. So please begin.
Okay, thank you. Thank you to everyone on the committee for inviting me to present the work that we do at Philadelphia Fight today. So first, I'm having trouble advancing the slide. Could someone advance the next slide, please?
Screen?
The slide isn't advancing. All right, there we go. Sorry about that. So just a little bit of background first on Philadelphia Fight. So we are a collection of community health centers that provide culturally competent, comprehensive primary care and state-of-the-art HIV primary care, mostly to low-income members of the community in Philadelphia. We see patients from every zip code in Philadelphia, and so really we pride ourselves on offering exceptional HIV primary care, but also general internal medicine care to individuals at risk for HIV. And that also includes people living with opioid use disorder. And here in Philadelphia, we've seen an exponential increase in opioid overdose-related deaths. Philadelphia Fight has risen to the occasion and incorporated opioid use disorder treatment into the care that we're already providing, meeting our patients where they're at and adapting our practices to help better manage opioid use disorder. So right now, we incorporate opioid use disorder treatment into two of our community health centers. One is called the Jonathan Lax Treatment Center, which was the one that was our first health center and really founded as an AIDS service organization about 25 years ago. And so at Jonathan Lax Treatment Center, we offer both buprenorphine and also long-acting and injectable naltrexone to individuals living with opioid use disorder. The second clinic is that we offer opioid use disorder at is called Clinic Star, which is a collaboration between Philadelphia Fight and Prevention Point Philadelphia. And Prevention Point Philadelphia is the only syringe service program here in Philadelphia. So 5 years ago, we received a SPINS grant, a Special Projects of National Significance, through the Health Resources Service Administration to found this clinic. And the idea was to really target individuals with a history of injection drug use who are not currently engaged in HIV primary care. So in addition to offering HIV primary care at Clinic Star, we also offer treatment for opioid use disorder. So again, buprenorphine and also long-acting injectable naltrexone. And the idea of offering, opioid use disorder treatment or medication-assisted treatment at both Clinic Star and the LAC Center is to offer as many co-located services under one roof, so that the patients that we see, particularly those with a history of opioid use disorder who tend to be very marginalized in Philadelphia, many are street homeless or at least very unstably housed. And the idea is to offer as many services that are co-located so individuals don't need to prioritize one life-sustaining medical intervention over another. And the way that we incorporate opioid use disorder treatment into care is really, it's an adjunct to the rest of what we do. And the idea being that if we dedicated one day a week or one half day a week to a medication-assisted treatment program, that maybe that doesn't fit into the schedules of our patients who often don't know what day it is, let alone the time of day. And so we're very flexible, not only with scheduled appointments for medication-assisted treatment for people who can make them, but also we allow walk-ins and certainly same-day initiation of buprenorphine and long-acting injectable naltrexone if individuals want that. So next slide, just to help remind me of the different kinds of medication-assisted treatment. So again, we offer buprenorphine and also long-acting injectable naltrexone, also sometimes oral naltrexone, and have the ability, we have medical case managers on site who can help patients. We refer to methadone maintenance programs if we think that if our clients need a level of care, structure, and support beyond what office-based buprenorphine or long-acting injectable or oral naltrexone can offer. And so, what we do in the office. So again, we try to be as flexible as possible, and we really incorporate it into our clients' individual medical appointment. So it's an adjunct in their appointment, like we would check someone's blood pressure at every visit. We assess people that have a history of opioid use disorder, for medication-assisted treatment, and if they're willing to start, we'll start that same day. When I first did the training for buprenorphine, part of the training said that, this isn't an emergency. You can assess people over several days and assess their willingness to start and make sure that they're in enough opioid withdrawal before starting. But I think now in the era of 1,200 overdose-related, opioid-related deaths in Philadelphia in the last year or two, if we turn people away to come back the next day or the day after, they may not come back. So what we do is, we see them in the office, again, in a very flexible way, and we have them sign a controlled substance agreement. And we call it an agreement and not a contract, because it's really an agreement between the provider. It's what I will provide to the patient, but also what we expect in return. We check in Pennsylvania, we have a drug monitoring program where we can check to see if individuals are getting other controlled substances, so either being prescribed MAT elsewhere or other substances like benzodiazepines, for example, that may interact with buprenorphine. We obtain a rapid point of care urine drug screen, which you can see at the bottom right is that composite of a number of different drugs that we would be concerned about, either because we don't want to, we don't want to we don't want to cause precipitated withdrawal. So we want to know that someone has opioids in their urine or not, or also check for other illicit substances that we may be concerned interact with buprenorphine. We've also started doing rapid fentanyl urine drug screens because a lot of the heroin, quote unquote heroin in Philadelphia, is not heroin anymore and is largely fentanyl. Which is, contributed to this exponential increase in opioid overdose deaths. But we do check fentanyl point of care because if we were to do the composite screen, and it would be negative for opiates, which would include heroin or morphine, the metabolite in the urine, it could be negative, and we would falsely give someone long-acting injectable naltrexone or feel comfortable initiating buprenorphine and not worrying about withdrawal when, in fact, they only have fentanyl in their urine. Now, this is not FDA approved, and so we're using this off-label, but we think that it's very important, for harm reduction reasons, to be using this on everyone initiating either buprenorphine or a long-acting injectable naltrexone, and then repeating, both the composite urine drug screening, point-of-care testing, and fentanyl. When we see patients, different providers will use them in different intervals depending on the patient. We assess for other comorbid mental health conditions and refer and treat as necessary. And then we assess the goals for the patient of initiating buprenorphine or long-acting injectable naltrexone, and ask questions like, what do you want your life to look like in a year? And again, we offer some same-day inductions if patients want that. We provide flexible appointment scheduling in general for all of our appointments, whether it's HIV primary care or general internal medicine care, and we also offer walk-in appointments. And then we have a lot of, as I mentioned, other co-located medical services, hepatitis C care, medical case management. Again, with the philosophy of offering as many co-located services as possible, so people don't need to prioritize, accessing one service over another. And then last but not least, we check urine pregnancy tests in all women of childbearing age who are able to conceive, because when buprenorphine is paired with naloxone as Suboxone, naloxone is pregnancy category C, and so is naltrexone, either in the long-acting injectable version or in the oral version. So, and this is just here to remind me to talk about, outpatient induction versus in the clinic setting versus home induction. And, we're finding, I think mostly because of the adulteration of fentanyl and pretty much all of the heroin supply in Philadelphia, as well as in the supply of other illicit substances like cocaine and methamphetamines and K2 or synthetic cannabinoids, that it's really difficult for patients to come into the clinic to initiate buprenorphine in sufficient withdrawal, to have a clinical opioid withdrawal scale score greater than 12 is really difficult for people to abstain from fentanyl, like to come into the clinic and then wait in the clinic, for the 6 to 24 hours of absence that are required. Occasionally we are doing in-office inductions, but I can say that largely, I would say maybe 75% of our inductions are now done at home, or at least outside the clinic. But for those that are done in the clinic, so someone who has either an appropriate withdrawal score or perhaps is coming out of the Department of Corrections and so hasn't used any opioids recently or coming out of a hospital setting, then we will induce them in the clinic. And then this is just to remind me to talk about the home induction piece. And again, I would say the vast majority of our patients, we're walking them through how to do this. And I think that management of these patients is probably one aspect of medicine where I've learned more from my patients than in any other. And a lot of the practices we do, I think, come from knowledge from them. But patients know when they're in insufficient withdrawal, and so we kind of walk them through how to initiate at home, and they know when to start. And so that's really for most of our patients what we are doing, helping them to know when it's appropriate to start, and usually starting it both in the office and at home with 8 milligrams of buprenorphine and 2 milligrams of naloxone. And generally we're using 1 tablet in the morning or film, and depending on what insurance in Pennsylvania will cover, and 1 in the evening. And the reason is fentanyl, because it has a very short half-life. People are using 10, 12 bags a day of fentanyl, and so using less than 16 milligrams of buprenorphine in 2 divided doses, we found does not control the physical withdrawal and also cravings in between. And one other thing that we're doing is providing or prescribing a lot of medications to also further mitigate withdrawal symptoms, particularly when people are using many more bags of fentanyl than perhaps buprenorphine should be able to mitigate the withdrawal symptoms. And so we're using a lot of diphenhydramine and hydroxyzine for the anxiety, and ondansetron for nausea, loperamide for diarrhea. We're treating the myalgias and arthralgias, and we do use some clonidine for the management of just a number of the opioid withdrawal symptoms. And then, one other thing I think is important to mention is, obviously, like when we're assessing response to buprenorphine or success, obviously we're using the urine drug screening and questioning patients about number of opioid-free days, and then looking at their urine drug screen to confirm that. But I think, especially in the era of fentanyl and this exponential increase in opioid deaths, with any decline in the use of fentanyl, we're making great strides in decreasing someone's risk of opioid overdose. And so, the ultimate goal, obviously, is opioid, continue to increase the opioid-free days and eventual complete abstinence, but just decreasing, at least slowly. I think we're making great gains. And then, in addition to, using the urine metrics, I think it's important to assess for things like weight gain and increased engagement in relationships with family and friends, perhaps change in their housing status. Do they go from street homeless to living in a shelter, or living in a shelter to renting a room in Philadelphia? And then finally, are they able to return to work or to school? Or are they engaging in other parts of their medical care that they weren't able to engage in before medication-assisted treatment? Are they finally taking their HIV meds and are virally suppressed? Are we able to finally talk about hepatitis C-related care? Or do we see decreases in abscesses and cellulitis? And then a little bit about how do we manage polysubstance use? And I think the thing to remember is buprenorphine and long-acting injectable naltrexone. Buprenorphine only treats opioid use disorder. Long-acting injectable naltrexone will treat both opioid disorder and alcohol use disorder, but they don't treat other illicit substance use. And so remembering that when the urine drug screen is still positive for other things, and not withholding or discontinuing the buprenorphine, but scaling up efforts to treat the other ongoing substance use disorders. So, one thing that we don't make benzodiazepine or alcohol use absolute contraindications to buprenorphine prescription, because they don't treat those. But counseling patients about the dangers of increasing respiratory depression. And then we also, if we see that people have ongoing use of other substances, that may prompt referral for additional counseling, for extra psychosocial support. And we also use, we try to prescribe other medications, some of which are FDA approved, some not, to help manage other substance use disorders. So, things like using disulfiram, fluoxetine, gabapentin, etc. for alcohol use disorder. And the nice thing about some of these medications is if people have co-occurring, other conditions like depression, it might be nice to pick something like fluoxetine that treats depression, and also maybe there's some data with alcohol use disorder using things like topiramate or sertraline for cocaine use disorder, and in one recent case series of using mirtazapine for methamphetamine use disorder, perhaps in someone who also has insomnia or some anorexia. So we try to use things, sometimes with some success, to manage ongoing other substance use disorder. And then finally, I think, as I mentioned before, that at least in our mind, in my mind, buprenorphine and long-acting injectable naltrexone as medication-assisted treatment really should be part of comprehensive medical care for people with opioid use disorder. And part of that, all of these individuals should be screened for HIV and hepatitis A, B, and C. If not immune to A and B, we should be vaccinating these folks for A and B and for tetanus, as we know, like the tetanus spores can be found in soil that can contaminate drugs or water that people are using to inject. We should be counseling all of these patients about the risks associated with sharing equipment. We should educate about safer injection practices. I really like to use a manual called Getting Off Right that is from the Harm Reduction Coalition, that was written in part by consumers in conjunction with service providers. We teach opioid overdose prevention, and we prescribe naloxone to all of our patients with opioid use disorder. I've started pairing monthly naloxone with their monthly HIV meds. So every time the pharmacy refills their antiretroviral therapy, they refill naloxone on a monthly basis. All these patients should have access to sterile syringes, either through syringe service programs like we have in Philadelphia at Prevention Point, but even patients who don't have access and don't have syringe service programs near them. I think all states except for Kansas and Delaware, medical providers who can prescribe other medications can prescribe syringes and needles for the purposes of HIV and hepatitis C prevention. And that website at the bottom at Temple University lists by state what the laws are for providers and pharmacies related to sterile syringe prescription. We should distribute condoms and screen for STIs in all these patients because we know that opioid use, a lot of my patients are doing sex work in exchange for money and drugs, or are participating in high-risk sexual behavior because the drugs cloud their clarity. We should be prescribing PrEP for HIV prevention in all individuals with a history of opioid use disorder. The CDC says that anyone who's injected even once in the last 6 months should be considered for pre-exposure prophylaxis. We should provide access to supervised injection facilities, which there's an ongoing debate in Philadelphia and a number of individuals here trying to open such a facility in Philadelphia in response to the incredible deaths that we've seen here. And then finally, we should educate all of our patients with opioid use disorder about the early signs of infection that related to injection drug use, so we can hopefully prevent some bloodstream infections and more serious infections like endocarditis and osteomyelitis and septic arthritis. All right, that's an overview. So thank you, everyone, for your attention.
That was terrific. We really appreciate you keeping in time. And now I'm gonna start the questioning by just saying you have what seems to me an incredibly integrated program that is doing some very good work. What were if you were going to pinpoint that, you go back in history in the beginning, what were the key elements? What made this happen?
I think I'm very fortunate here at Philadelphia Fight. I think, it's always been kind of, I don't know, to use a better expression, cutting edge, that we always have wanted to meet patients where they're at and adapt to, um, what was going on with our patients at the time. And so I think, very early on when we started to see this incredible surge in opioid-related deaths here, we decided very quickly, we need to do something about this. Just as if our patients, all of a sudden, we had an epidemic of hypertension, we'd all figure out how to treat that. It's kind of,
Sounds good. I'm going to ask now committee members to, you can't see them, I guess, but to ask them questions. So who wants to start? Okay, David.
Please introduce yourself.
This is Dave Gustafson. So a patient leaves your clinic, and they've been in other clinics also, and they're talking to a friend, and they're saying, the thing that's different about this place is, what would they say?
I think they'd say, I feel welcome, I feel treated with dignity and respect. I feel like they meet me where I'm at, and they really try to work with me.
Good. Excellent. Holly?
Hi, thank you so much. This is Holly Hagan from NYU. Thank you so much for that overview. I wanted to ask you about your harm reduction philosophy. I mean, you brought it up a number of times as you were talking about the services. And I guess I wanted to ask you that as you brought in, it sounds like you brought in more clinicians or people who perhaps hadn't had a long history or experience working with people with opioid use disorders. How did you, were there any concerns or sort of barriers to integrating them into the culture that you have at Philadelphia Fight?
Yeah, so I think we do, we work very hard to do a lot of training here. And, and one thing I didn't mention was, I started early on doing Narcan or naloxone trainings, and part of that, opioid overdose prevention, and then also part of that really just a harm reduction training. So I think just by doing more and more training, we've been able to bring a lot of people on board. And I think when people are empowered with education, it can, and otherwise, things can be scary if you don't have knowledge about them. But I think, just more education has really empowered our entire staff to be a part of combating this epidemic.
Did you encounter any challenges with respect to developing this shared philosophy with new staff, perhaps?
Yes. Sometimes I think sometimes there's some frustration or misunderstanding, and I think really what I've tried to do is part of this education is reframe opioid use disorder as a chronic disease, and putting it in those terms as if we were treating diabetes or hypertension, and that people will remit and relapse just like with any chronic disease. And it doesn't mean that that's a moral failure or a character defect on the part of the individual. And it's going to take a worldview change, and it's not just here at Fight, but everywhere. And even with the patients themselves, they're often very reluctant to discuss when they've used again because of all of the stigma and shame still surrounding opioid use disorder.
Thank you.
Dave.
Hey, hi, this is Dave Thomas from Johns Hopkins. I wonder if you could tell us a little bit more about how you distribute the work and or the roles. Would there be, for example, a primary care provider that would do all of this, that one physician or MP or something like that, or would some of this be done by a nurse and some of it by a social worker and some of it by someone else?
Yeah. So thank you. So I can speak here at the LAC Center. We have 8 providers. At Clinic of Yenny Star, I'm the only provider. It's a smaller clinic, so it's me. But here at the LAC Center, there are 8 of us. 5 of us all have X waivers, and in Pennsylvania, as of maybe a year and a half ago, both physician assistants and nurse practitioners can prescribe buprenorphine. So, it's a mix, and we really cover for each other, so that if, one of my patients comes in on the day that I happen to not be here, there's somebody else that's available. And so what that kind of looks like is someone would present at our front desk, and the front desk would find someone who's available to initiate or refill the Suboxone. We have medical assistants who will do the urine initially, and then also we have a pharmacy tech who runs all the PDMPs and keeps up. Luckily, we don't have prior authorization issues. That was something very new, that if you order either the formulation that Medicaid will cover, most of our patients are on Medicaid. As long as you order the formulation of buprenorphine that's on formulary, prior authorizations are not required anymore. So that's kind of how that looks, and we are very much participating in a team approach to this. And then we also have medical case managers, and most of these patients are going to have medical case managers. They have other psychosocial needs that require that, and they also work in very close contact with the providers, helping patients if they need additional individual therapy to get that, and check in, make sure patients are coming in for their regular appointments. And then one other thing I can mention is that before each clinic session, so we see patients from 9 to 12 and then like 1 to 4 here each day. So for the 5 minutes before each clinic session, we have a brief huddle where the entire medical staff, so medical providers, front desk staff, the medical assistants, our practice coordinator, all run through the list of the patients that are coming in that day. And so I can look through my list, and and each of us do, and say, all right, this patient is coming in for Suboxone. They're going to need a PDMP. They're going to need the urine, and so everyone's on board. So that's that's how it works. It's not always seamless, and certainly, I recognize that adding something else into primary care when we're all doing so much is one of the things. But again, I think we saw the great importance of addressing this, because other than HIV and hepatitis C, opioid use disorders causes the greatest mortality for our patients.
So if you were to be talking to one of your primary care friends somewhere else, or a substance abuse treatment person, and they did say that to you, like, look, I'm already very busy with what I'm doing, I feel overwhelmed already, how would you encourage them to adopt a model like what you have?
So, I think for patients, specifically those with opioid use disorder, a lot are going to have co-occurring HIV or hepatitis C or serious bacterial infections. And what I'll say is, if you're not addressing the opioid use disorder, which is really the cause of everything else, that other stuff is going to continue. And if you're able to address the opioid use disorder, probably your manage of them gets far easier, because either HIV will be better controlled, or you're preventing HIV infection. Same for hepatitis C, and the same for the serious bacterial infections.
Hannah?
Hey, thank you so much. I really appreciate this. Oh, I'm Hannah Cooper from Emory. So we're really interested in the kind of a biography of the program, and I'd love to learn from you more about the process of setting up this integration. Were you with the organization when this was established, when this was first set up?
Yes, and I was so buprenorphine. I've been with the organization for 8 years, and there's actually some buprenorphine prescription happening when I started, but I've really been responsible for scaling that up, and I'm also the one who introduced the option of having long-acting injectable naltrexone available to our patients, and also the one who started all of the naloxone, the Narcan training, and pairing that with other medications.
So what exactly did you need to put into place to create this integration?
Well, I think, because the buprenorphine was already happening, so as it turns out, we do have an intensive outpatient treatment program that's part of Philadelphia Fight. I can say that it is largely still a 12-step program, and so I think for opioid use disorder, it hasn't always been the best fit for some of our patients, but at least because we have that, I think everyone is already on board with scaling up, and so when patients need an IOP or individual therapy, I do tend to refer out. But again, I think because at least we already had a good deal of buprenorphine prescriptions, scaling up just really required people being on board with it. We have a pharmacy department here at the LAC Center, and we're able to manage keeping long-acting injectable naltrexone on site that we get through specialty pharmacies and our pharmacy department. I can say that when I started was at the time of both Cepravir and Telepredor, so the first direct-acting antivirals for hepatitis C, and so a lot of their efforts were managing all of that and cytopenias, and so now that we have very tolerable hep C medicines, they needed something else to do, so they've been able to help far more with buprenorphine and long-acting injectable naltrexone.
Sandy?
Hi, thank you. This is Sandy Springer from Yale School of Medicine, and I appreciate your presentation and your hard work. A couple of questions. As also a provider of buprenorphine and extended release naltrexone, I understand the challenges. I had a couple of questions. How are you doing same day extended release naltrexone inductions in those who are actively addicted, or are they reserved more for those who are coming out of inpatient settings?
Yeah, I mean, that is definitely a challenge. And I think when I've had the greatest success is when patients are coming either out of the Department of Corrections and coming directly to us. Sometimes we've had success when people come out of hospitalization, so they haven't received opioids during the hospital admission. Unfortunately, we have not had great success when people are using fentanyl on the street and having them wean off, for the required time, 7 to 14 days to be able to initiate, and that, is definitely, one of the downsides of long-acting injectable naltrexone. We have, in a lot of the programs here in Philadelphia for weaning people off of fentanyl and other opioids, utilize buprenorphine and methadone, to wean people off, and then you still have another 14 days to wait. So it's been a challenge, but
right.
when we can, people, and also, to give, the other thing I didn't mention is, which MAT version to choose for patients, and one thing that we pride ourselves on is, including the patients in that and helping them help us decide what is the best way to go for them.
Great. How many total patients do you think you've been seeing between the two clinics, and as you said now, 6 providers who are providing opiate use disorder treatment?
I think there's 5. So I think we looked at this recently. It's between 200 and 300.
Okay.
Just to give a sense, we have about 1,700 patients total at Philadelphia Fight. So a good percentage.
Yeah, that's very challenging. And the funding for one of the programs is through a SPINS grant. Is that correct?
Yeah, for Clinica Bieni Star, it had been through a SPINS grant. That ended about 9 months ago, and then we were able to bring Clinica Bieni Star in under the FQHC umbrella. So it's actually officially now a satellite FQHC site of Philadelphia Fight.
Great, thank you.
So this is Jody Rich from Brown. Great presentation. I'm wondering, we're all trying to think how to expand this type of model across the country, and I wonder if you just had some advice for us in terms of how to get to where you're at from, for other, have other FQHCs around been seeking advice or any thoughts you have about how to expand this type of model?
Yeah, so I guess one thing that we've done in Philadelphia, so we have a health federation which does a lot of trainings here, HIV for they have like an HIV preceptor program, a Hep C preceptor program, very recently a medication assisted treatment preceptor program that I participate in. So people who, so individuals who maybe have their X waiver or maybe have only started prescribing or in the process of obtaining it, and just need some extra support in implementing. So I participate in the lecture series, and then those individuals actually come to our clinic and see what we do. So one piece of advice would be to pair up with other people that are already doing this, and really just go to their clinic and see how they're doing it. And beyond that, again, I think that we've just been able to make it happen with extra hard work and education of everyone here. Because of his, and I think a lot of FQHCs and Ryan White funded clinics and AIDS service organizations have had to be creative over time, and this is just one more piece of that.
So you just spoke the F word, so I'll stay there. Tell us about your business model.
Our business model?
Yeah, who pays for all this? How do you survive?
Yes. So we are Ryan White funded, and we're a federally qualified health center, and then also we have a 340B program, and so it's 340B pricing for buprenorphine and long-acting injectable naltrexone.
Sounds good. So maybe that's also the secret ingredients. Robin?
Hi, Robin Newhouse, Indiana University. So you mentioned one of the valuable things that helped you was the support for implementation. Can you just tell us 3 things that were most important? What kind of support is it that you needed?
So I think mostly the support of the medical staff. I mean, because we're only all as good as the people who greet patients at the front desk, and the medical assistants who get their urines, and the pharmacists who are supporting them. And so I think, again, I'm going to go back to the education piece, that when people are empowered with education and learning about opioid use disorder, instead of just seeing patients who are coming in demanding their buprenorphine, maybe there's none in their urine, but helping people understand how we can better support people. So then I need 2 more. So that's one. I guess the other piece, I really needed buy-in from our executive director, and who's Jane Scholl, and she's really known to be super innovative, as one of the most innovative and intelligent women I know, and just having her support, so we can't do it without her, but just I think her believing in the ideas, the innovative ideas that all, and for me to be able, she allowed me to apply for the SPINS grant to start this clinic in North Philadelphia, in the epicenter of the HIV, Hep C, and opioid epidemic. And I think the last piece is the collaboration. So if an organization doesn't offer something, collaborate with others in the community that do. And so I think that collaboration between Philadelphia Fight and Prevention Point Philadelphia opened up much more access to services for our clients here. So access to the syringe exchange and the harm reduction practices. And also, when you collaborate with others like that, you learn so much more. I've just learned volumes, from the individuals who've been working at Prevention Point for decades now. And then also, because we're in Center City, Philadelphia at Fight, and they're in North Philadelphia again, and like the epicenter, they've established this amazing trust in the community there. So, building on that collaboration, because the patients trust them, and then by association trust me, has been really helpful.
Dave?
So if somebody came to you and said, we'd like to start a program like this, what would be the biggest mistake they could make?
Oh goodness, I guess maybe expanding too quickly. You know, start with a small number and make sure it's working, and work out the kinks. And you know, because that's kind of what we were able to do at Prevention Point with the clinic there, because it was a spins and we were enrolling people over time. We could work out any problems, you know, early on. So yeah, start small. Don't overwhelm. Don't enroll all of the. I mean, it'd be great to enroll everybody at once, but also if the program fails, you're helping no one. So maybe start small.
Excellent. Ellen?
Yeah, thanks. This is Ellen from UAB. I'm really pleased to see that you all are offering PrEP, and I'm just curious if you could tell us a little bit about the providers and how they're selecting which patients. For example, is it just folks that are reporting recent injection drug use? Is it all folks with illicit substance use because of sexual risk behaviors? And then also thinking about the patients, have they been receptive? Do you see many of them willing to accept a prescription for PrEP and then also continuing to use PrEP as prescribed?
Yeah, so Philadelphia site was actually one of the first clinics in Philadelphia to offer PrEP, mostly initially to young MSM, and that program has been very successful, run by one of my colleagues, Helen Koenig. We aren't offering PrEP to people who inject drugs on as large a scale, and you know, it's another project that is in development, but I would love to be able to offer PrEP. So Prevention Point has a weekly syringe exchange line, Friday afternoons, like on-site in their main center. Throughout the week, they have vans, you know, that people can go to at different neighborhoods in Philadelphia. But I would love to be able to offer PrEP as a weekly Truvada when people come in to pick up their weekly injection equipment. And you know, so really as a gateway to, and that's what we found with our youth program for PrEP, or our young adult program for PrEP, is that it really became a gateway to primary care. And it would be the same for this, that it would be, you know, that PrEP would be a gateway to other care for individuals who inject drugs, for Hep C care and for medication-assisted treatment, and just for HIV care if necessary, and then also just general primary care.
Thank you.
Edwin?
Edwin Chapman, Howard University and Medical Home Development Group. Congratulations on a fabulous program. How do you measure success? How do you show payers that what you do works? Do you use retention rates, or what measures do you use? I know this is difficult because you do so much, but could you give us an idea of how you convince payers of your success?
Yeah, so I can speak for Clinic Vianney Star, and we're very proud that 12 months after people were enrolled in care with us, and at Clinic Vianney Star, the inclusion criteria is that someone had to have a history of injection drug use. So everyone had either active or very recent, like in the last six months. So at a year after enrolling folks and everyone living with HIV, 83% were virally suppressed, and I think that compares to about 86% with other Ryan White funded centers. So there's that, and I think, you know, obviously we look at you know, urine drug screens and opioid-free days and what patients report. But I think one thing I always do is I weigh people. I ask them about their housing. You know, is their housing stabilized? We ask patients if they're repairing relationships with family and friends, so that they have more social support. And you know, we're asking about returning to other, you know, meaningful activities like work or school. And then, you know, and as I mentioned in the beginning, looking at, are they better engaged in the rest of their health care? So are they taking their antiretrovirals when they weren't before? Are we able to talk about hepatitis C treatment? And we, you know, certainly don't we don't make abstinence a prerequisite for hepatitis C treatment, but I certainly ask patients if they think they're ready and able to take a pill or 3 pills every day. So that's those are the metrics that we're assessing.
Holly?
Yeah, I just wanted, this is Holly Hagan from NYU. I just wanted to follow up and ask you, is the syringe exchange also on site in either of the clinics?
No, so it's only at prevention point. So syringe exchange is still illegal in Pennsylvania and only legal in Pittsburgh and Philadelphia by executive orders. And so prevention point is the only legally sanctioned syringe exchange. But there are providers, there's stigma associated with accessing service at prevention point. So there are providers who will prescribe syringes and needles for patients, which is permissible in Pennsylvania and can be dispensed by pharmacies, and the indication just needs to be prevention of HIV and hepatitis C.
Thank you.
Hannah?
This is Hannah again. Thanks so much. So we know that populations of people who inject drugs are quite diverse in terms of age, gender, race, ethnicity, class. And I wonder if you could speak at all to your sense of the program's coverage for diverse populations of people who inject drugs, both in terms of recruitment and also retention across time.
I think, like I said, Philadelphia Fight really sees a very good cross-section of the population living with HIV in Philadelphia and also of people with a history of opioid use disorder, as does Prevention Point. A lot of our patients are street home. About at least 40% of our individual patients I see at Clinic Epidemic are street homeless. The clinic, the name obviously, well-being clinic in English. We picked the name Clinic Epidemic because 5 years ago, a large number of the patients living with HIV and opioid use disorder who were not engaged in HIV care in North Philadelphia were of Puerto Rican descent. And over time, over the last 5 years, new people who, individuals who are new to opioid use disorder and injection, become increasingly more Caucasian and younger, and that's reflected in the patients that we're seeing in the clinic. A smaller and smaller percentage of people of Puerto Rican descent over time. We are in the midst of a hopefully mini HIV outbreak in Philadelphia. We've seen about 100% increase in new infections over the last year, most attributed to injection drug use. And a lot of those individuals who are also seen at Clinic Epidemic are young and Caucasian. So young, I mean 20s to 30s.
So this is, I'm going to take the prerogative of asking a question right now. This is Dr. Del Rio from Emory and the chair of the committee. You said to us about this outbreak happening in Philadelphia, and obviously your program, your excellent program, is sitting in the midst of an epidemic. And it seems to me like a lot of things that will need to happen to make this sort of a standard is changes in policies and politics. You said to us, needle exchange is illegal. If you could list some of the things that you would like to happen to make this easier, what are those things that will make the adaptation of programs from a policy and politics perspective easier to happen?
Yeah, so I think one is access on the part of insurance companies to all formulations of buprenorphine and doses, and not governed by the insurance company themselves, but based on consultation between the provider and the patient on what's going to be the best formulation. I wish there were more kind of non-12-step, maybe more harm reduction programs for that, to complement medication-assisted treatment for extra psychosocial support. I think a lot of the 12-step programs have not been, have worked well maybe for alcohol use disorder or cocaine use disorder in some individuals, but not as, not have been shown to work as well, same outcomes in people with opioid use disorder. So I'd love there to be more harm reduction programs that not only teach people living with opioid use disorder about the disease, and so they understand the cravings and the physical dependence, but also, support them with counseling and to avoid the triggers and understand what triggers their use. And I think also there's a committee here in Philadelphia, and also they founded a nonprofit organization, a safe injection facility, and I think we really need them in the United States. The first one opened in Switzerland in 1986 at the time, because the Swiss recognized that they were in the midst of an HIV epidemic from injection drug use. And there's Insight in Vancouver, which has been the largest study, has clearly shown, not only in the surrounding neighborhood around Insight, but in Vancouver as a whole, has greatly reduced injection drug use related deaths, and also increased access of people to care. And so, I think the goal for all of us is to get people into care and to have them stop using. But the idea of the safe injection facilities is to keep people alive, or until they're ready or have insurance or whatever it takes to get them into treatment.
Terrific. David Gustafson.
This is Dave Gustafson again, yes. When I first asked you, what would a patient say about your organization, your responses could have been all sorts of areas, such as I could get in anytime I wanted and things like that. But you said, and then later on came back to it at least once, that feeling welcomed, being treated with dignity and respect, and that kind of stuff were the first things that the patient would probably say. Can you help me understand that a little bit more?
Sure. So I think, because, and as we've alluded to before, I think, even amongst medical providers, there's not great education. We don't get great education in medical school about substance use, and so I think there's still a lot of misconceptions, and shame and stigma imparted by the medical field and people with substance use disorder that don't. We understand, but don't conceptualize that this is a chronic disease that relapses and remits and is not a character flaw or moral defect. And so I think patients, I've had a lot of patients tell me firsthand of the poor treatment that they've, had in other places, in local hospitals and other clinics. And so, it's so simple to treat people with dignity and respect and say, we're going to manage this together, just like we're going to manage HIV and hepatitis C and diabetes and hypertension.
So again, I'm just going to follow up on that. When I think about where I practice an HIV clinic, we have spent a lot of time educating providers. We can say what we want about dignity and respect, but we spend a lot of time educating people about, transgender and LGTB, a lot of education to providers to try to not assume that just because you work there, you don't have a baggage and stigma and other things. Anything that you've done to address provider education around stigma and substance abuse management, because again, people come with a baggage that you have to deal with.
Yeah, no, we all have our implicit bias, and we do implicit bias training. Philadelphia Fight runs AIDS Education Month. The month of June, we have all kinds of workshops. We have a full day in our local convention center here, and with topics on all of these subjects. And we close, the entire organization is closed for the day to allow everyone to go and be educated. So, it's, and I hope, I guess also people walk through, there's some self-selection. People walk through the door or want to work here because they know the work we do. So we're starting with at least some tolerance and education.
Robin?
Yes, you started, Robin Newhouse, Indiana University, you started by talking about designing services toward the needs of people that use substances. And I'm just wondering if your patients are involved in any way, or how did you learn that? Or do you have an advisory committee? How do patients inform the process so that you know what and how to design?
Yeah, I mean, I think they definitely do, and my practice has changed, and that's on the individual level. But I definitely ask patients. I guess there's two things. Is one, just the individual prescribing of medication-assisted treatment, which I think like anything we do, we need to have constant communication with our patients about what's working, what's not working, how they're taking it, how they're not taking it, because some of our, and I think unlike any other chronic disease, our patients come with a ton more knowledge about substance use, and particularly opiate use disorder, than we do, and how to use, and a lot come having already used buprenorphine either on the street or previously, and those people are going to have far more success than individuals that have never ever used. And is there more to that that I should talk about? I guess then there's like the whole program in and of itself. And I think we hire a lot of people near peers, and so we have some community health workers here at the LAC Center, and then up at Prevention Point we had we started an outreach coordinator, care navigator, who was also a near peer, so someone who had grown up in the community, had a history of opioid use disorder use herself, but was pretty far removed, and so I learned a ton from her, about how to engage with individuals and how to best structure the program.
This is a great discussion. I just want to be mindful and remind the committee of your time, but also remind the committee members that we have exactly 5 minutes left, and we got 3 questions. So I'll fairly quickly questions and answers. David?
Dave Thomas. I wonder if obviously you believe in what you're doing, that it's part of comprehensive primary care, and all QHCs are required to provide comprehensive primary care as a condition of getting their 330 grants. Have you given any thought to ways to ensure, like, are there metrics that you could suggest that would be measurable, that would ensure that all primary care had minimum basic integrated care services like what you're doing? I mean, maybe not to the full scale, but I hate to use the word quality measures, but have you given any thought to, even within your own QA programs, of how to assess whether or not what you're aspiring and providing is actually occurring?
Yeah, so I think again, and I think someone had asked, like, this is a lot of extra stuff to do, but I think also that when you offer this, it self-stabilizes in each individual patient who's on MET, but then a whole group of patients, and so really the work for those individuals. I mean, if you're talking about this, burden's not the right word, but the workload for the individual provider and the clinic, I think, goes down as the patient's needs become less, as they become more stable. And so looking at HIV viral suppression, so were they not suppressed before, and now they weren't adherent to their antiretrovirals before, and now are they able to treat Hep C and prevent reinfection? Are we decreasing the number of antibiotics that we're prescribing for abscesses and cellulitis, or number of abscesses that we're draining, or hospital admissions for injection drug use related complications? I think those are all things on a big scale. And then maybe more earlier on, as I mentioned, looking at weight gain, maybe housing stability, because also as the patients get more stable, again, their needs and the workload for the clinic become less, and less case management interactions because their electricity isn't constantly being threatened to be turned off, or they didn't get kicked, they didn't get evicted from their apartment again because now they have, money to pay their rent. So there are a lot of other things I think that can be looked at, and ultimately less resources. If maybe there's this intense resource up front, but over time those individuals may utilize less resources in the clinic.
Okay, two more questions. Edwin.
We've had much difficulty with top-down authority in terms of who remains in treatment and how they're treated. Have you had an impact, or do you have a mechanism for giving information or impacting public policy? I know that prior authorizations are gone in Pennsylvania, but have you had the ability to impact public policy? And if so, what's the mechanism?
Yeah, so very fortunately, I was chosen to sit on our mayor's task force to combat the opioid epidemic, and that was about a year and a half ago now when it was convened, and I sat on the Public Education and Prevention Task Force, and so we were able to make 5 recommendations to the mayor and therefore to the Department of Health. Many of those are being carried out, and a few would be some of the changes in the prior authorization process. There's also the implementation of when medical providers in Pennsylvania renew their medical license every other year. They now have to take an opioid course of some kind, either an overdose prevention or safer opioid prescribing course prior to renewing the medical license. There's been a public health campaign to expand access to Narcan, and so there's been a number of interventions. Because and I have to maintain my contacts with the people at the health department, and periodically, if they have questions about things, because they're not doing this, they're involved in the day-to-day care of patients living with opioid use disorder. But I get to ask a lot of kind of more practical questions.
Hannah, you get to ask the last question.
Thanks so much. I really appreciate all this. This is Hannah. Can you describe one change that you've made to the program since it opened, and just tell us why you made that change, what prompted it?
Yeah, I think I alluded to this way back in the beginning, and and I think when I first started prescribing buprenorphine, and this goes for the clinic as a whole, we would ask patients to come back. If they came to the clinic and they weren't in sufficient withdrawal to be able to induce them with buprenorphine, we'd ask them to come back the next day or maybe the day after. And that was really before fentanyl, started really adulterating our heroin supply here in Philadelphia. And because of that, and because of the exponential increase in opioid-related deaths, we either induce people the same day or just do far more take-home so that they have that, in a place maybe they're more comfortable than in the sterile clinic, to be able to induce that later, so that we're not asking them to come back when maybe they don't return, because every subsequent time they use is a chance of fatal overdose.
Well, I want to say thank you very much. I really appreciate your time. Dr. Banford, this has been incredibly illustrative, incredibly useful, and congratulations on your program. I'm sure we will probably be going back to you asking even more questions that we hear from other programs. But if I'll give you the last couple minutes if there's anything you want us to know or anything that we've missed that we should know.
No, I just like to say thank you for allowing me to talk about our program, because I'm very proud of the work that we do, and I wouldn't be able to do this without amazing colleagues and team that I work with. I just thank you for letting me brag about it.
Well, you should be proud, and you should brag more about it, quite frankly. So I'm going to now end this morning session, and we will break for lunch, and lunch is on your own downstairs in the cafeteria. Unfortunately, there's nothing else around here except for the cafeteria. And we will see you back here at exactly a little before 1 because we have Dr. Sarah Hearn from Whitman Walker joining us at 1, and that'll be in person. Thank you. Go ahead and get started. So please take your seats. This afternoon, we're starting with having Dr. Sarah Hen from who's the Chief Medical Officer of Goodwin Walker Health, who's joining us to talk about their experience with integration. So again, Sarah, what we hope to do in these discussions is have you talk to us for about 15, 20 minutes or so maximum about your integration. We want to hear a little bit about, I would say, almost the biography of the program, about how it happened, about how you do it, about the facilitators, the challenges, and then we're going to go around and the committee will ask some questions, and again in a very sort of dialogue kind of way. I don't know if you have anything about epidemiology or anything like that, but we would love to see if that not presented, just focus on the program and what you're doing. I think that will be very useful. Okay, thank you.
Okay, so yeah, so I'm going to talk. Can you please? Yeah. I'm going to talk to you about my experience, or our experience here in DC. So Whitman Walker Health is a community health center in Washington, DC. We have 2 clinical sites, a nice modern site in Northwest that's relatively new, and then we have a very vibrant site in Southeast in Anacostia. And these are our 2 clinical sites where we provide care. Just to give you a little perspective of our history, because I think it tells how we came to integrate substance use treatment into care, is that we started from a place of activism. So we started as a VD clinic for gay men in 1973. We grew up during the AIDS epidemic and responded largely to that. So we were the first gay community-based medical unit in the country devoted to the evaluation and diagnosis of AIDS in 1984. And our services grew up around the need to respond to that epidemic. And so from the beginning, we had a very integrated care model because we were responding to the needs of people in the community. So we had a volunteer-led helpline for gay alcoholics called WAS. It's one of our oldest programs. It still exists. It was the Whitman Walker Alcohol Services Program. It's now the Whitman Walker Addiction Service Program, but it's part of our history. We also had housing and a food bank. We have the longest standing medical legal partnership in the United States. We hired our first attorney in 1986 to advocate for the needs of our patients. We had dental services. In 1987, we started an addiction recovery house for gay men mostly. And then in 1991, we became a Ryan White clinic, and really that became what we were really for the next 10 to 15 years. We were an AIDS service organization. And I say that we were an AIDS service organization, not a community health center, because all of our services focused around treating HIV and the needs of the community. And that model really became no longer financially viable in the early 2000s. And so we had to have a new business model. We had subsisted previously all on grant funding, donations, Ryan White. We weren't a traditional community health center in the sense that we didn't bill insurances. We just had grown up. And so in 2006, we decided we needed to become a community health center. We merged with the Washington Free Clinic, and we started doing primary care for the first time. And so that was new for us. We had previously only done specialty care, HIV care, and we had done some addictions care, but we hadn't done primary care. We continued our HIV, dental care, behavioral care, psychiatry, and our medical legal partnership, but really started billing insurance and becoming what you would think of as a community health center, and became an FC lookalike, and then a full-blown FQHC several years later. Can't move forward. Okay. So currently we serve over 20,000 patients. Our largest growing community of patients are gender nonconforming individuals. We serve close to 2,000 transgender and gender queer individuals. We care for almost 3,600 people living with HIV. Most of our patients live in the district, and 40% identify as Black, 17% identify as other or mixed race, 37% are white. So our patients really reflect the district. Our patients do skew a little younger than a lot of other primary care clinics because of our expertise in gender-affirming care and HIV care and PrEP. PrEP is the other big driver right now for us. We have over 1,000 PrEP patients, and that's something we've seen grow rapidly in the last few years. So the opioid epidemic in DC, this is probably one of my few epidemiology slides, but there's been a radical increase in deaths in DC, 178 increase in fatal overdoses. Most are among African Americans, and most are occurring in Ward 7 and 8, which is where our Anacostia clinic is. And one of the things that's very different about the opioid epidemic in DC is most of the people who are dying are long-term heroin users. So heroin use has been a chronic problem in the district for a long time, but now people are dying from it more than they ever have previously. And that's really because of fentanyl. So fentanyl getting into the heroin is causing deaths that we hadn't previously seen. So a lot of the people that we're seeing who are overdosing have been heroin users for 10, 20 years. A lot of them were already patients in our clinic. So how did we start MAT at Whitman Walker? It was initially siloed within behavioral health. So we had our WASP program, which was an abstinence and harm reduction program back from the early 80s. We had a psychiatrist. Our psychiatrist in the mid to late 2000s got a buprenorphine waiver and started doing MAT therapy. But it required engagement with behavioral health and required group therapy. It was located only in Anacostia at our Max Robinson Center. And so this really created a bottleneck with few providers able to see patients, but a high demand for services. It also left our medical providers feeling helpless to engage a lot of patients in care. We have another program called our MORE program with our medical providers. It's a mobile outreach and retention engagement unit where we go out, we identify patients with detectable viral loads who haven't been seen in care in the last 9 months, and we go out and we find them and we provide services in their homes or another location that they identify, so they don't actually have to come into the clinic. And one of the, and working on this program, our medical providers absolutely noticed that the patients we were seeing, the two things that consistently made them more likely to be a MORE patient was the use addictions or behavioral health disorders. I mean, those were the two problems, the two barriers that they were experiencing. And so it was very clear to our medical providers that they needed to increase their skills in taking care of these patients. So we trained an additional psychiatrist. Several medical providers obtained waivers, but still weren't really comfortable prescribing. So if a psychiatrist went out on vacation, they would cover the prescriptions, do prescription refills, but it's still really all the care was happening within psychiatry. So about 4 years ago, our psychiatrists, because they were at capacity, started referring stable patients back to medical for maintenance of therapy. And that was really the first time that the medical providers began to gain some confidence in managing patients in a limited way. And more medical providers started obtaining waivers. From there, we work to develop a rapid entry into MAT. So about 3.5 years ago, along with psychiatry, primary care, and psychiatry partnered to develop a rapid entry into care. And we based this program off our red carpet program for same-day entry into HIV care. So for a long time, we've had patients that can come in, they can say they're there for red carpet services, they see a provider the same day, they get started on treatment. We do the same thing for PEP. So the providers already had
blocks on their schedule to accommodate these patients on call for red carpet, for PEP. And so we based this MAT program off that. And we called it Welcome Mat. Welcome to MAT. So, and the goal really was to reduce overdose deaths, engage people in medical and behavioral health care, and reduce overall risks for morbidities associated with substance use disorders. So patients can walk in or call and ask to be connected to substance use disorder treatment, including MAT. Patients are able to see a primary care provider with a data waiver. They fit into the existing call schedule. We do long-acting buprenorphine. We also do long-acting naltrexone or oral naltrexone. We have a peer addiction specialist, and that has been very helpful. And we also have individual therapy, behavioral health, addiction specialist support groups, and psychiatric care. So patients who are more complex, have co-occurring severe mental health disorders that also have to be managed can be referred kind of up in care to the psychiatrist. But we basically aim to identify and link patients and begin treatment the same day. And we use a risk reduction model for care. So if a patient calls for MAT, what will happen is they'll be actually transferred from the call center to our addiction specialist. And the reason for this is the addiction specialist will screen them over the phone, talk to them. They can ask them what insurance they have, but they can also give them instructions for presenting to clinic, having not used for enough time, so they're starting to be in a little bit of withdrawal. So they will talk to the patient about how much they're using, what kind of treatment they're interested in, and come up with a plan for when they should last use and when they should present to clinic. That way they can walk in, see a medical provider, an MAT provider. They're scheduled as an appointment, and they can have an induction done the same day. So they're scheduled 3 to 5 days out from that initial phone call, and then they have a 40-minute appointment with the medical provider. They are induced, and then a warm handoff is provided to the peer support specialist. And the peer support specialist has really been critically helpful to the medical providers because they're someone who's available in clinic. We can grab them, they can help out, but they're also someone who can really relate to the patient. They come from a place of experience which our providers don't have, and so they can relate to the patients in a way that our providers cannot. The peer then will talk with the patient, assess other behavioral health needs, and decide with the patient if they want to engage in any additional behavioral health support. So that could be individual therapy, group behavioral health therapy, or a group led by the addiction peer specialist. Or the patient could decide right now they just want to stay engaged with medical and they don't want any other support. And that often changes as that relationship goes on. If a patient walks in, it's a very similar model. They see the provider the same day. They generally aren't induced the same day. They aren't started on buprenorphine the same day. But they meet with the provider, expectations are set. They are asked to return in 3 to 5 days for a scheduled induction. They do meet the peer support specialist the same day, and they are given the option for other group therapy as well. We use a risk reduction model. I mentioned that before. We really aim to meet patients where they are. We encourage trust building and good relationships. We do not expect patients to be completely abstinent, and in fact, we are not always surprised when we see other use go up when they become clean from their opioid use. So often we'll see cocaine or alcohol use increase with other. So we work with them, talk to them about the risks of that, but we try to have a very open and honest relationship so that they come to us and will tell us what they're struggling with so we can help. But we absolutely do not kick people out of the program for a dirty urine. You aren't pushed to the curb. We've done a lot of naloxone training and distribution in our clinic. We have a standing order on both our clinics have on-site pharmacies. There's a standing order at both pharmacies signed by myself. So any patient can walk in and ask for naloxone and they can get a prescription there without even talking or engaging with their provider. we do chart audits with our providers to make sure that all our patients who are on anti-narcotics have a naloxone order, but we really try to make sure that all staff know and make sure that patients know about naloxone and access it. And we will work with patients to taper use too. And finally, I guess one of the other things that the peer support specialist has been really important for is connecting to other community resources. So often our patients will come in and, you know, by getting sober, they're giving up often income if they were dealing. They're often giving up their friends, their family, their social networks. And so the peer support specialist can be very helpful in helping to create a new social structure for them.
Does that mean working with patients to taper use?
Exactly that, kind of talking to them and saying, well, how much are you using now? You don't think you're ready to go on buprenorphine, but can you decrease your use to by this amount, X amount? This is how much you're using. What if you just reduce it by 20%? And let's make sure you have naltrexone. Who do you use with? And let's make sure they have naltrexone, and talking to them about that. Why MAT in primary care? I think sometimes for patients, it's easier to enter care in primary care. It's less stigmatizing. And it's also a great opportunity to engage in primary care and screen for other diseases such as HIV, hepatitis C. So I think we really see substance use disorder like a chronic illness, and try to be as much of a one-stop shop for patients as we can be. What has allowed our program to thrive in medical? I think first and foremost is probably our organizational culture. We are a mission-driven organization that came from a point of advocacy. So, I mean, you know, our 40th anniversary t-shirt there is on the right, Fighting Stigma, Saving Lives. That was made kind of reflecting on our history as an HIV center, but it absolutely applies to substance use disorders as well. And we have a history of integrating specialty care, ID care into primary care. So behavioral health and substance use disorder addictions treatment into care seems like a natural progression based on the needs of our patients. It's been really important to have ongoing education for our providers. It certainly helped initially having a psychiatrist who had experience prescribing and managing buprenorphine, but now it's really, it's over the course of time, it's really transitioned to something that the providers themselves own. There are providers in medical who've become real advocates for the program. They organize brown bag lunches monthly to do monthly case conferences around addiction, and this is something that really just grew out of the program and the need to share knowledge. And so that makes it much easier for new providers starting to prescribe. It gives them kind of a support network, a place to ask questions in a structured way. And then again, I would mention our addiction peer specialist has been very helpful. So barriers to uptake. I think one of the big things is it requires a lot of flexibility. The nature of the disease is that people have trouble showing up to appointments at a time. They have trouble navigating the health system. So, and that's very hard to fit into a traditional clinic structure where we want to run on time and have scheduled appointments and be out at 5. And that, you know, life doesn't work like that. So we had to think creatively about how we could fit it into our call schedule so that it would work for everyone. And we do have to be flexible with patients. The data waiver training has been a barrier. Certainly the Comprehensive Addiction and Recover Act, which expanded training to PAs and NPs, has been greatly beneficial. I would say that at least half of our prescribers are PAs and NPs. And I will say in general that we have everyone from infectious disease physicians, internal medicine, family practice, PAs, NPs. The people who have trained, who chose to go into generalist careers from the beginning are much more likely to pick this up and do it. You know, I mean, those of us who became infectious disease physicians, we want, you know, 3 years of fellowship training and then we're ready, then we're comfortable. But the number of hours of training for PAs and NPs, it's unclear why 24 hours is needed versus the 8 for providers. And then the number of patients. So NPs and PAs cap out at 30 patients. And although, none of our providers are doing majority MAT prescribing. So we don't need enormous caps, but when you talk about cross coverage, if you write a prescription for someone, that becomes one of your 30 prescriptions. And so things like that we bump up into against. And then the experience of our providers is that the training has not been as practical and clinically based as they needed to be really comfortable to initiate prescribing. So I think we really ran into a problem where we had a bunch of providers get waivers, but then no one was ready to use them. And so it wasn't until we had a real medical advocate within medical who was ready to stand up conference regularly, get the psychiatrists available to curbside, that people really developed the comfort and the support that they needed to start managing on their own. Yes.
You mentioned that patients don't show up on a reliable basis, and then I missed what you guys do about that.
We try to be accommodating. I mean, simply, we try to be accommodating. If people show up 15 minutes late, we try to still see them.
Sandy Springer from Yale School of Medicine. I just had a question about that. So if you have problems for them to come, and then there's not a same-day induction and asked to come back in 4 days, do they show up?
Usually, we're getting better at that. So really knowing how to support patients through some mild withdrawal was really important. And I don't think that's something that people learned kind of getting their waiver. And so as long as patients know, because patients are often really scared. They know what it feels like. They've been through it before. They don't want to feel sick. So as long as you can really, they know who to call if they run into a problem. They have prescriptions in hand, so they know how to treat symptoms. They're really pretty good. But it took us a while to learn what was appropriate to provide for them, to provide that support. Because if you just say, oh, come back in 3 days, that's not going to work. So the other, barriers to uptake. So certainly our addictions peer specialist is something we fund out of the goodness of our own heart to a large degree. It's a non-billable position. We have some grant funding for it, but it's certainly here and there. There's the inability to bill for group therapy through Medicare. Medicare doesn't allow billing of same-day appointments with medical and psychiatry. And under Medicare, licensed professional counselors are billed under a psychiatric provider referring the client to care. And so those are things we have to work around and create obstacles for us. The other obstacle for us is the HSS 42 CFR Part 2 regulations. This our compliance officer has spent a lot of time thinking about recently. So Part 2 programs are prohibited from disclosing any information that would identify a person as having a substance use disorder unless the person provides written consent. And Part 2 regulations take precedence over HIPAA when a higher level of protection is provided. So the treatment, payment, and healthcare operations exception that applies under HIPAA is not applicable. So what that means for us is, what does it mean to be a program? Are we a program? And they define a program as an individual entity or identified unit in a general medical facility that holds itself out as providing substance use diagnosis and treatment. So we have to be very careful how we portray our services. A MAT team, for example, would be an identified unit. However, a PCP who prescribes substance abuse services incident to their primary care is not. And so we actually, we had an attorney submit an inquiry to SAMHSA asking if a member of the general medical facility staff who does not work within the Part 2 program assesses the patient's record in the EHR and views substance use records covered by Part 2, has an unlawful disclosure occurred? And SAMHSA responded, it depends on whether or not the provider has consent to view the record. So that was very concerning to us. So I think, so we are currently in the process of creating additional consents for all our patients in substance use treatment, just so that within even our own facility, we can all view the record without worrying about that. So my take homes. So an integrated approach has absolutely increased our ability to provide treatment. We've gone from having 2 to 14 data waiver providers. We've really focused also on simultaneously increasing naloxone training for all our prescribers and pharmacy staff. And we found that having a low barrier entry into care allows for quicker access to medication and improved retention within our facility. And our patient population in the first 6 months of this program increased almost 4-fold. And it's been great to be able to integrate primary care along with substance use treatment and also increase screening and treatment for HIV and Hep C.
Thank you very much. That was really good. So I'm going to go ahead and start and say, you know, you gave us sort of the history of why this started, and you again touched on something that we believe in, which is, you know, this whole issue of meeting the patient where the patient is. But how was this environment of wanting to move this in this direction? How was it perceived within the clinic, the administrators, the providers? Or did you feel there was resistance getting there, or was that everybody was on board right away? And how did that happen?
Everyone wasn't on board right away. So, you know, I think one of the things I didn't touch on, oh, I didn't realize we're on camera now. One of the things I didn't touch on was, I think the other benefit we had is we have a very active research site. And so some of our first opportunities into MAT treatment came through opportunities within research. The first opportunity probably happened 8 or 9 years ago, and we actually had to back out of that because of concern that it would upset other patients in the waiting room, it would disturb the flow, and we had to regroup. So it's been a gradual process of over really 8 to 10 years of talking about it and slowly pushing it forward.
That's great. I want to open it now to the committee members to ask questions. Dave? Put your little tents up so I can take your names down.
Dave Thomas at Hopkins. Thanks a lot for that. That was really extremely helpful. I wonder if you could say more about, I know it sounds like you've given a lot of thought to the financial aspects of sustaining this, and if you were to be talking to another medical director of another FQHC, of all of what you do, is the substance abuse bit that you brought in more recently, is that financially cost neutral itself, or is that cost you and then you have to make up for it somewhere else? Or can you say a little bit about what you're doing that loses you money and what you're doing that makes money and how it all works together?
Yeah, I think, so in general, we lose money seeing patients. So we don't make back the cost of a patient visit, really for anyone. So, you know, we depend a lot as an FQHC on our pharmacy. And so in comparison to our other medical services, is this more of a loser than seeing a patient for primary care? No, it's probably about the same. There is a cost, there's a cost of the addictions peer specialist, and there's the cost of some of the patients. Like we will allow patients with Medicare to be in groups if they want to be in groups, and we just don't charge them. So there's that cost that we're kind of leaving on the table. the number of patients who we engage in care who then go on to be diagnosed with hepatitis C or HIV and then get treatment, I mean, that may make that up, but I haven't done that math.
And is it, just follow up on that point, is it the pharmacy contribution, is that specifically from the Hep C and HIV drugs, or is it also from the BUP and the other?
Yeah, it's from others as well. So, I mean, all of our patients who are engaged in primary care, if they use our pharmacy, if they choose to use our pharmacy, and they can obviously choose another pharmacy if they wish, but if they choose to use our pharmacy, you know, we will qualify for 340B pricing on those patients and that really is mostly an advantage for our to us, for our patients who have Medicare or who are privately insured. So for Medicaid, we get just a replenishment model. So we don't see a profit on the pharmacy side from our Medicaid patients. So part of our business model has always been that we have a mix of patients, because we actually make more money seeing Medicaid patients in clinic, but we lose more money seeing privately insured and Medicare patients in clinic. But the reverse is true on the pharmacy side. So we want a diversity of insurers in our patients, ideally.
David Gustafson. Dave Gustafson, University of Wisconsin. So suppose I was talking to a patient of your organization who had been in treatment in other places in the past, and I was to say to them, what's different? What would they tell me?
We're not going to kick you out. You know, even our own approach to treatment, I mean, we used to require patients to be in more intensive outpatient group therapy, and we've really found that that's a barrier for patients. It may be a barrier because they're trying to work. It may be a barrier because they're embarrassed. They have stigma around their illness. For example, I have one patient, he's been a long-time HIV patient of mine. He's now engaged in our MIAT program. He doesn't want to attend groups because he used to deal to the people in the group, and he feels guilty about that. So we don't prescribe any specific treatment to anyone. And we try to tailor the treatment to the individual. And I think that's really very different from even how we approached this 5 years ago.
Holly?
Hi, Holly Hagan from NYU. So it sounds like your agency has undergone a philosophical shift around the treatment of people with opioid use disorders. And I just wanted to ask you to elaborate a bit more on what you did to overcome some of that initial reluctance.
Just kept poking. Yeah, I think it's really important to have lots of conversations within your organization to get buy-in. I think, and different stakeholders within our organization had very different concerns. So, you know, for me to get buy-in of the providers, I need to show them evidence. You know, for me to get buy-in of the CEO, I need to show them that it's financially not going to be detrimental. You know, so everyone had a different concern, and listening to those concerns and then and allowing them to validate their concerns. I mean, it's pretty basic, but I think for any change to happen, there has to be a lot of time for conversation. And so it often seems like it's moving very slowly at a glacial pace initially, but if you give time for those conversations and keep, you know, that you can make those changes happen.
I'm going to follow up a little bit on that before going to Hannah, is if you were sitting here or going to some other organization, and granted, we're all different, but if you were to come to my clinic to tell us, do this, you would say, do the conversations, have a champion, but what would be the other, do you think it's good to have a multidisciplinary team that brings this up, that drives this? How would you drive this? What would be the sort of key ingredients to driving this in other places that you would tell them put in place? And I would add to that, and what would be the things that you would tell them, don't do this, this was a mistake?
I think it is good to have a multidisciplinary team. Not absolutely necessary, but I think it is good to have someone who has experience doing this. So in our case, it was our psychiatrist. So being able to work conjointly with psychiatry and medical. But then I think, the providers were able to push this along. Because they saw the need. And I think ultimately that was, once the providers saw the need to improve care, that they saw this is what they were running into, that their patients' HIV wasn't controlled or their diabetes wasn't controlled because they weren't able to address a co-occurring disorder, that is what ultimately pushed this along.
Hannah?
Thank you so much, Hannah from Emory. You have two different sites, and they
Yes.
look quite different.
They're very different. We're trying to rectify that.
So how has the integration kind of proceeded differently at those two different sites?
It has, because our Southeast site is really where our MAT program started. It's where our psychiatrist did MAT therapy for the last 10 years. It's located in Ward 7 and 8, which is where the opioid epidemic is hitting the hardest in DC. So there was much quicker buy-in there than our nice, shiny new site. And part of that is also because just the physical layout. Max is a much smaller site, so everyone doesn't have a choice but to be on top of each other. And so that really creates kind of interdepartmental communication much better than at 1525 in Northwest, where we all are spread out. We're among multiple floors, and it's sometimes harder to find someone. So, at Max, it's very easy to find the addiction specialist because they're probably like sitting like practically on top of you, So that was more of a challenge. So it definitely, and it took scaling up at Max for the program to take foot at 1525, because I think then the benefits we're seeing in it.
Just a follow-up question. Do kind of other residents of the community, are they aware that you're prescribing buprenorphine? Has there been pushback to that at all?
We haven't gotten any pushback. The awareness is in the community through word of mouth, but we haven't gotten pushback.
Just a follow-up. In both of the sites, would you say that most of your patients are still LGBTQ, or is that different in the Southeast site?
Perhaps a little bit. Overall, about 50% of our patients are LGBTQ. So it's very split, 50-50 down the middle. And our Northwest site is probably more 60-70%, and our Southwest side is probably more 40-50%. But it's still, they're both pretty diverse.
I'm going to add, before going to Ellen, tell us a little bit about, your composition as far as your payer source, because you talked about Medicaid, Medicare, right? You have a Medicaid expansion site.
We have
here.
Medicaid expansion.
So tell us how your because obviously I think that the payer determines a lot of what you are able and not able to do.
Absolutely. So our patients are about 50-60% Medicaid, 30% privately insured, and the remainder 10 or 15% are Medicare. And then DC has a benefit called Alliance, which is for people who can't otherwise qualify for Medicaid, people who are undocumented. And so we have a remainder who have that program.
Yeah, this is Ellen Eaton from UAB. I think most of what we talked about was relevant for HIV-infected folks, and I'm curious about any services to Hep C mono-infected or the PrEP clients that may integrate with these same treatment options.
So this program it's an entry through primary care. It doesn't matter if you have no other medical problems, if you have hepatitis C, HIV, if you want to engage in PrEP, it doesn't matter. All our providers treat HIV, a lot treat hepatitis C, so most of the time that can all be taken care of. There's a single stop shop.
Thank you.
Terrific. Julie.
Hi, I'm Julie Baldwin from Northern Arizona University. You referred to this in your last slide, but I wonder if you could just expand a little bit more on the types of data that you're collecting to evaluate your program.
I think we're looking kind of at numbers, how long do people stay engaged, if urines stay clean. We haven't really had an opportunity to evaluate it further in terms of how many people use it as an entry into like hepatitis C care or HIV care. We haven't tracked that at this point, but that's certainly something we want to look at.
Hi, Sandy again from Yale. So a couple of questions. If again, going back to the you said that you're not doing home inductions yet or same day. Can you say if you're planning on that or why you aren't doing
We are
that?
doing same day. We're not doing home.
You're doing, oh, you said if you're not inducted the same day.
Yeah, some people will come in and they won't be able to be induced the same day, so they'll come back. You're not sending them at home. I think we may grow into that. I think we're still at a point where we're getting comfortable with what we're currently doing.
And how many do you think you have on buprenorphine or Vivitrol, extended release naltrexone?
We have only a handful on extended release naltrexone. The vast majority are buprenorphine. We probably have a few hundred.
Do you think that this integration, the ability to provide MAT, has in any way impacted your HIV metrics, for example, retention, virologic suppression?
No. So we actually, one of the interesting things is I think heroin users are in some ways very different than amphetamine users, and that especially in the district, a lot of our heroin users have been users for a long, long time. And so they're very structured around their use. And so we actually were part of CTN 067, which was Choices Scale Up. We had really, really impossible time finding patients whose HIV was uncontrolled who were active users, because all our active users were controlled.
Pretty interesting. Hannah?
So you have a very diverse population. I'm wondering if there are still groups that you feel like you're not reaching, pregnant women, or just populations that you think might be falling through the cracks of this integrated program.
Yeah, we're not reaching pregnant women. Our patients are largely men. They're largely in their 40s and 50s. They're older. We aren't reaching prescription pill users yet. I don't think we've really figured out how to engage them without I think patients who are on prescription opioids for pain, we haven't figured out a good way to engage them in buprenorphine for management of their chronic pain.
Sandy.
A couple of questions. So you were saying the viral suppression, you're seeing your people who are using heroin, who are in care, that they're
pretty
yeah,
good.
I see that too. But the group though that I treat and seems to still have the same problem like Jody's is those coming out of prison and jail where their treatment might be interrupted, so they may not maintain viral suppression. Do you see groups coming out of prison and jail, and do you link them or start treatment?
Yeah, we don't
And
have.
I would add to that, do you have any
hospital.
specific linkages to your, criminal justice?
So Unity Healthcare in DC has the contract with the prisons. They're another big FQHC. They're the biggest FQHC in the city. They have a program. They continue MAT in the prisons, but they also see most of the patients who come out. We will get patients who are HIV positive coming out to us, but we don't see that as a big problem in DC.
And and so you were saying the issue with the prescription opiate users and having difficulty kind of identifying them, and do you do a universal for all your patients an opiate use disorder screen, even in those who are receiving prescription opiates, or do you?
Yes, we do.
And then discuss treatment? Okay. There's some programs like Oregon who are utilizing buprenorphine as a treatment for pain. Opiate use disorder. I don't know.
Yeah. I've heard from them about they're doing that from time. But we have it. We do screen. We do urine tox screens on all our patients who are on opioids, and we do try, but.
Yeah, I mean, you talked about your evolution and really transforming in 2007 toward these integrations. So I'm wondering if you ever thought about specific implementation strategies that you found were effective or ineffective in terms of helping to foster the integration of infectious disease and the addictions programs.
I wish I could say that we were that we had that much foresight, that we had an implementation in mind. I think it really, for us, it honestly grew organically from the programs we had. And I can't say that we had any strategic
Ellen Eaton again from UAB, and I should have said earlier, thank you for sharing. This is really wonderful and impressive work. Thinking about the client-patient perspective of a site that historically served men who have sex with men and focused on sexual health, I'm just curious the implications of that for focusing on treatment of opiate use disorder, and if you see fewer heterosexual men for that reason, or if you feel like you're seeing a pretty diverse group in terms of patients.
I think we see a pretty diverse group. I would say that our opioid use, our MAT program, is not mostly gay.
I'm from Birmingham, Alabama, so we're always talking about intersections of stigma.
Yeah.
And, there's, sexual minorities and racial and ethnic, and now substance use disorder. So thank you.
Jody Rich from Brown. This is a really great description, great program. I'm thinking about that 8 to 10 year kind of organic change, and I mean, describing a culture change, but within an organization that is founded in activism and responding to patients' needs and epidemic needs, and we're trying to come up with some way to try and replicate this. And I'm trying to think about this culture change. Is there a way that it sounded like it was for the physician providers or the providers as opposed to the front end staff, and then maybe some of these peer workers. I'm just wondering, do you have any way of sort of having a consistent, culture throughout the organization, or do you have any thoughts on how we should suggest replicating something like this elsewhere and maybe more quickly?
Yeah, I mean, I don't know that I have a great answer for that. I think I think it really was based on responding to the need and having people recognize the need in their communities and how they serve those communities was really the driver for it. I think and I think that was critical for buy-in on every level. And I think, certainly too, I mean, our evolution also helped, it corresponded with the evolution of the epidemic and the coverage of the epidemic, right? So I think it absolutely helped that everyone was hearing about it in the media as well, along the same time.
So you talked a little bit about something that seems to be important to me is flexibility. And it seems like, at least those of us in HIV clinics, we've seen over the life of our HIV clinics, flexibility. I mean, I remember our clinic used to be a place, we had a treatment and holding place where we would do CMV infusions and do palliative care of people in the pre-heart area. And then when heart appeared, we changed it into something different. And now we're using our treatment and holding area for the place that we can do buprenorphine inductions, et cetera. So, I mean, I think our clinics tend to adapt as the epidemic has moved. But I'm thinking about our ID clinic, which is not an HIV clinic, which is very structured and very rigid in the way they do things, how they do outpatient antibiotics. And the non-HIV ID clinics, a lot less flexible, a lot less ability to change programs. Any advice for places that are so, how do you incorporate it into something that is very structured already?
I mean, for us, kind of the light bulb moment was realizing that we had a call schedule already built in to take people on a walk-in basis. I mean, that was a light bulb moment for us because we were doing it for rapid ART starts, and we were doing it for PEP, and we had this schedule already built into the system to accommodate people walking in, and it was a light bulb to say, hey, let's use that same schedule for this. So that was really, and that was really the light bulb moment in terms of figuring out how to be flexible with the schedule to allow it to grow.
Dave?
Yeah, I'm sorry. I'm going to take one more shot at this question where we try to get you to help us just because you've learned so much and you've been through this practically. So let's say all of a sudden you were empowered by HHS to solve the problem nationally, not just in your clinic. What would you do? And so I'm asking you to go beyond your immediate circumstance and think about what structural barriers exist that you would all of a sudden be empowered to solve if you were in charge of HHS or at least their agent on this.
Well, I get rid of, the CRF 42.
I got that one down already.
That's why I had that as a slide.
Yeah.
I would absolutely find some way to pay for peer addiction recovery specialists because they're unlicensed, they can relate to community, they can move without a schedule. Some type of.
And would that be in the 330 money that comes the grant money, or would that be like because otherwise you have to change Medicare billing or something?
You have to, either some mechanism to bill for their time, or some mechanism, or maybe some built-in mechanism for the drug reimbursement, or I don't know, but some kind of funding, because I think. They are a person that we were very skeptical to hire because we didn't have a good way to pay for them. And now that we have them, I can't imagine the program without them. And I think there needs to be, especially if I think about a solo practitioner sitting somewhere. Our brown bag lunches have been very important for new providers, learning how to do an induction, manage withdrawal symptoms, titrate medications, And those kind of things aren't really covered in the data waiver to the degree that they need to be. So there's something called the Trans Line, which it's a group of community health centers, and we all respond to emails for gender affirming care. And any provider anywhere in the country can email you a clinical question saying, I'm seeing this patient, how do I provide gender affirming care to them, or what do I do? What would you do in this situation? And we'll give them a response. Something like that, where you could take your clinical question and say, this is what they're using, this is the symptom they're having, what would you do? I'm not sure to do X or Y, Z, and you could get a response back in 24 hours. Because I think it is, it is intimidating to learn on the job in an area where you got no training. I mean, I got no training on this, right?
And would you change the training requirement? Would there still be, is that an obstacle? Is that a necessary obstacle?
Do you want to answer? It's absolutely an obstacle, and I don't know if it's as practical as it needs to be, and I don't know that and I don't see the utility of the increased hour requirements for PAs and NPs.
I don't even see the reason why I needed to do 8 hours of this as a physician, which quite frankly could have been on the job. And what I find totally weird is that I had zero training to prescribe, or opioids, and I have to take 8 hours of training to prescribe this medication. It makes absolutely no sense. I mean, it's just totally ridiculous. But anyway, that's our health system. I'm going to remind people we have 5 minutes left. Then we have 3 people. So rapid fire questions. Hannah, you start first.
So I'm very interested to hear that you have the on-site pharmacy. I think that often falls through the cracks often. Did you have to do anything to get the pharmacist on board to dispense buprenorphine? That's my first question. And then, there's that the DEA monitors the percent of controlled substances that are dispensed that are opioids, and I'm wondering if that's created any issues for the pharmacist if they dispense buprenorphine.
We have a very, very busy pharmacy, so I don't think we've reached that level. So that hasn't created an issue. And our pharmacists were great to work with. So we meet with them regularly anyway, about once a week, to run through operations, talk about patient issues, look at better ways to improve delivery and care. And, we've done other initiatives with them. We have a prep clinic, which is staffed by health educators largely, where patients will come in, get their annual, every 3-month screening and get their medications kind of all at once. And so we've worked out ways to deliver medications so we had some precedent there with them in terms of working on specific programs. So,
Holly?
Just a quick one. So do you have syringe services, safe injection training, cooker cotton distribution? Is that available on site? How do you manage that aspect of the harm reduction, especially in support of people who are undergoing HCV treatment or?
Yeah.
Yeah.
So we certainly will provide syringes through our pharmacy, but we don't have an active needle exchange program. There are several great needle exchange programs in the city, and we take advantage of working with them. But that's probably something we could work on.
Okay. Well, I think we're going to say thank you.
Thank you.
This was terrific, Sarah, and I think you have a great program. You have a lot for us to learn. And I think what Dave said is actually true. This is a committee charged by HHS, and if we need to tell HHS about policy issues that need to be changed, this is going to be an opportunity to do that. So, again, this is not just a one invitation. When you go home and you think about other things we need to let the committee know, please notify us. Please talk to us, because again, I think we are in the midst of a crisis, and it's a crisis and opportunity to make the changes that we need. So thanks for being here, and thanks for all you're doing.
Thank you.
Two down, and now it's 2 p.m. We're going to ask Dr. Andrew Talal, who's a professor of medicine at the University of SUNY Downstate in Buffalo, to discuss this program, telemedicine to integrate hepatitis C and substance abuse therapy. So thank you for being here.
Thank you very much for the invitation, and thank you. Just a disclaimer, some of the work that I'm going to describe is being funded by the Patient-Centered Outcomes Research Institute, and these are my own views and not the Board of Governors, and don't reflect the Corey's views and additional funding from those commercial entities. So what I'm going to discuss over the next 20 minutes or so is a telemedicine model for HCV management among opioid use disorder patients on methadone that we've implemented throughout New York State. Just a little discussion of what are the issues, some data from an early study that have been published, which are referenced at the bottom of the slide, proof of concept study currently being conducted by or supported by PCORI, and then considerations for implementation of the model into the real world. So the concern for hepatitis C is that off-site referral is largely ineffective. And so several years ago, we asked the question, why do patients not go from methadone programs to liver clinics, and the patient discomfort with seeing the providers? There's also provider stigma, lack of knowledge, our barriers to treatment, and also HCV providers, at least heretofore, have been limited at some of the OTPs. And indeed, in New York State, data as recently as 2017 suggests from the New York State Department of Health suggests that only 20% of OTPs are actually treating HCV. So several years ago, we asked the question, could we use telemedicine as a model to link the individuals in the methadone program with the liver care specialist, and thereby bring the HCV provider to a familiar and comfortable environment for patients with hepatitis C? And really, what is the potential of telemedicine? Well, conceivably, all of these individuals may be involved in the care of patients with hepatitis C. And what does telemedicine do? Well, it removes the geographic barriers to high-quality, cost-effective care. It allows access to specialists statewide, and it also can facilitate direct communication between providers. So in other words, the hepatologist can be speaking directly with the PCP or the addiction medicine specialist. And really, if we want to think about improved specialist communication, this is the web of complexity that one may face when treating patients with hepatitis C. And a lot of these interactions can be facilitated via telemedicine. And so what we're thinking about is really the concept of creating the virtual medical home. And so where you have the patient with HCV and all of these individuals who are involved in that patient's care all can have the ability to communicate virtually. And this is really a concept that we're currently in the process of investigating statewide at 12 sites across New York State, 6 upstate, and 6 in New York City. You can see, and we have provided coverage to almost all metropolitan areas in New York State, with the exception of Albany. And really what telemedicine does is it removes the geography from the ability to provide high-quality, cost-effective healthcare, and it permits providers to treat patients statewide from the same location. So I can be in my office in Buffalo, and I can see patients in the same morning in Brooklyn, in Syracuse, in Buffalo, right down the street, and in Rochester at the sites in which we're working. And so the model is illustrated here. So we have an OTP patient who's screened for hepatitis C. They're shown a 7-minute video about telemedicine and what to expect. They then have an initial patient evaluation and a discussion on HCV. And you can see there is a model actually that we use to describe the stages of fibrosis with the patients. And the patient actually has the same model in front of them. We work to document in the electronic health record at the site, as well as with the site staff. We order HCV medications through a specialty pharmacy, and they're then delivered to the methadone program and are dispensed with methadone with take-home doses for the days when the patients aren't able to come. and bills are submitted electronically. So in a pilot study that was published just about 6 months ago, 42 out of 45 patients, or 93% of telemedicine patients who were treated, achieved viral eradication. We asked patients as part of that earlier study, what is the preference for integrated HCV care via telemedicine? And using something called a previously validated instrument called the Telemedicine Satisfaction Questionnaire, which has 14 questions about telemedicine, and this was largely a middle-aged African-American, non-Hispanic population, actually from northern Manhattan. And so a lot of them had never been involved in any treatment via the computer. And we administered the questionnaire at the first time at their first evaluation, when they started Hep C treatment, and then at the third time, or 6 months after they completed treatment, which is when we assess for sustained virological response. And if we ask, and what you can see is, so looking at 3 separate questions, the preference for integrated care via telemedicine, I prefer to see the doctor through the computer rather than go to an off-site clinic. You can see there was a gradual shift, so in red and in green are either disagree or undecided. Dark blue is those who agreed, and light blue is those who strongly agree. You can see there was a gradual shift over time. Similarly, for the convenience, so the concept of one-stop shopping, which is something that we've heard previously, I think the consultation via the computer made it easier and more convenient for me to see the doctor than going to a hospital or a clinic for treatment. You can see similarly there was a shift over time as patients became more comfortable with this type of interaction. And finally, if they perceive that it's more convenient and they prefer it, would they recommend medical treatment via the computer to a friend? And you can see others thereby also began to refer their colleagues for treatment via the computer. So if we think that referrals to HCV providers off-site, which is largely the way that most programs address hepatitis C, we ask the question, can we bring HCV treatment to patients through treatment integration into opioid treatment programs? And so the first question is, why integrate HCV treatment into the OTP? And I'm sure all of you have been thinking about this. Well, HCV has a high prevalence and a very high incidence, increasingly among OTP patients. Addressing HCV tends to improve overall health, as we've heard today from some of the other speakers. OTPs, at least methadone programs in New York State, have strict attendance and medication adherence requirements, which we can leverage for telemedicine interaction. And the model appears to improve treatment uptake and medication adherence. They're more if they get their medication for the Hep C with their methadone, they're more likely to adhere into complete treatment and subsequently return for sustained virological response. And arguably, but I think generally accepted, OTPs are a familiar and comfortable setting for patients in which to receive treatment, and many OTPs have mission statements to deliver comprehensive health care. So what do we need to implement telemedicine as a model in the real world? Well, there are multiple levels of support for successful integration. So really, you need a local champion, either a provider or an administrator to lead the effort, and that's what we learned by getting the 12 sites to work with us. You need to ensure that the integration aligns with the OTP's mission. And that, again, was something that we also learned. You need support, of course, from the executive leadership of the OTP, as well as the healthcare system. And you need the participation of the frontline staff, i.e. nurses, case managers, and the receptionists. So what are some of the challenges? Well, different OTPs have different motivations. And this is something that we learned very pragmatically when we were setting up this network. Some had liability concerns for treating HCV. It's not within our mission, or we're not willing to accept the risk. Lack of experience and knowledge in treating HCV was a frequent issue that was cited. And I think one needs to consider at least overtasked staff. So what we've learned, at least from our OTPs, is that many of them have high staff turnover, which is something we have to think about ongoing and as we design our educational interventions. So what you really require, which I think is a common theme with the previous two speakers, is a culture within the OTP to integrate via telemedicine or for treatment of co-occurring conditions. And you need a culture and a mission to provide that provide a strong foundation for the integration of HCV. So OTBs can be considered a social system. And substance users typically state that they feel accepted and less stigmatized in OTPs than when they're referred off-site or they go to conventional healthcare settings. At least in New York State, staff provides needed support to patients. So by regulation, counselors, social workers, nurses, and other healthcare providers must be available at a regulated ratio of provider to patient in order to be licensed to operate within the state. OTP integration promotes the concept of a medical home. We're making it virtual instead of what was considered previously the on-site medical home. And peer support and word of mouth really promote participation in telemedicine. Patients trust other patients. They self-identify as a community. And what we've heard from others is that the patient advocates may be very influential. So those who've gone through the program serve as the best advocates for expansion of the program. The concept of one-stop shopping. Patients prefer on-site telemedicine treatment over off-site referral, and on-site HCV treatment promotes adherence. So again, what are some of the challenges? Diverse program motivations, and I think some programs have liability concerns. What are some of the key factors to successful integration? You need a local champion. You need staff support and advocacy. Patients generally trust OTP staff. For telemedicine, you need obviously the space in which, or at least an exam room or a conference room in which to set up a computer. You need broadband access. The telemedicine provider needs access to the OTP's healthcare medical system, either directly or at least the ability to fax the note over and then have it integrated into the EMR. We need ongoing education for telemedicine for both staff and patients. I mentioned the frequent staff turnover in this setting. So we visit annually each program and conduct hepatitis C education. We've also produced educational videos. We have a patient advisory committee and share patient success stories and have preceptorships for providers who would be interested in developing the ability to treat hepatitis C themselves. And then we have to overcome perceived patient barriers. And these are some stigmatization concerns regarding publicly receiving medication. So if they're getting the hep C medication, in some sites it's done privately. In other words, they go into a specific room and only one person is being medicated at a time. In other places, there's a line. And so, people are receiving online. So we've had to discuss in certain situations how we're going to dispense the hep C medication confidentially if anybody has brought that up. And also early on, we've had to address patient concerns over the novelty of telemedicine, the interaction, and privacy. So privacy concerns, who's listening, who has access, is it a private network? That's why we made the video going forward, so that video addresses a lot of those concerns, which we learned from our pilot study. We've discussed a lot today about a business model. So what about integrated care via telemedicine as a business model? Well, the OTP's mission is to serve as a medical home, at least in many instances. Thankfully, telemedicine is increasingly reimbursable. And one of the areas that we're working on with New York State Office of Alcohol and Substance Abuse Services is reimbursement for multiple patient encounters occurring during the same day. So if a patient sees a telemedicine provider, they also see an addiction provider, they go for counseling, they go to group, they go for medication administration. Each of those should be billable as a single encounter, and that's something that we're working actively with New York State OASS. I've already mentioned some of the challenges, but I think just to suffice it to say here, there are differences in the OTP mission, and some of this requires cultural change. Some OTPs see themselves as very narrowly focused only on substance use treatment. And I think this is general for not only for hep C, but telemedicine telemedicine visits have generally lagged behind those of in-person visits, and I think is one of the areas that we're going to have to address as a healthcare field if we're really going to have if telemedicine will have the impact. What are some of the perceived advantages to the patients? They like the one-stop shopping. There's decreased stigmatization in the OTP compared to conventional healthcare establishments. There are reduced privacy and confidentiality concerns when all of their healthcare is co-located under the same roof. There's the ability to obtain specialty care in the OTP, which in some of our focus groups is something that patients themselves have identified. I'm able to get treatment right here from a specialist who sees Hep C, and that's all he does. And the ability to then obtain, and then I think it builds upon the trust between the provider, the program, and the patient, and the fact that you're taking care of all of their needs, not only just their substance use treatment needs. What are some perceived advantages to liver specialists? Well, this is telemedicine perhaps, but is also important to acknowledge here, but it's the ability to see patients, I would argue, more efficiently. And it's reduced impact of scheduling misadventures. So we've discussed that this population does not keep appointments. This was brought up recently. Well, if there's a telemedicine provider, they can be in their office doing whatever they do, and an alert will pop up, and they'll see the patient, and they can then see the patient. So they're not losing time going to a different site, sitting there waiting for a patient to show up. So that's one way in which this may reduce and the flexibility as we scheduling flexibility. There may be more via virtual than in-person visits. It removes geographic barriers to providing high-quality care. So the provider can manage patients in multiple regions in one session. And it promotes collaboration and integration with other specialists. In other words, frequently the hepatologist or the infectious disease physician, whoever the liver specialist is, can speak to the addiction medicine specialist. And so for patients who might be going through difficulty with their substance use, we'll co-formulate plans as to when to approach the Hep C. And we do that so they may come only once a week. If they're in detox, we can schedule their telemedicine appointments on that day. So while they're in the Methadone program, they're also seeing the telemedicine provider. And it promotes patient adherence. So for the OTP staff, I think it improves overall health of patients in the OTP. It enables addiction specialists to address highly prevalent healthcare problem for which specialty knowledge at least is an initial requirement. It improves patient knowledge. Patients often report greater interest in their well-being and an increased desire to take care of themselves after they've completed or are participating in Hep C treatments. And so finally, what are some of the challenges to integrated care? Well, it requires organization within the OTP to bring external telemedicine providers. So there's a whole host of credentialing issues that need to be addressed, including credentialing, billing, contracts and agreement, and patient scheduling. There's regulatory approval. So OTPs have multiple regulatory bodies, federal and state, each with different specific requirements. So if it's a hospital system, if it's a community-based system, if it's a freestanding system, each one may be regulated by CARF or by the Joint Commission. So you have to think about what are the policies of telemedicine of each of those regulatory bodies. You have to ensure that telemedicine fits within the mission of the OTP, which we've discussed before may require a cultural shift in some situations. You need engagement and participation from the staff. So really the frontline healthcare workers can really make or break the success of the integrated treatment. One needs to think about the cost of the equipment, which thankfully has been decreasing. And this is not only the hardware of the computer, but also the software, and you want computers that make the patient feel that they can see the person, and you need to have a reliable system and make sure the broadband to the site is satisfactory, so the visit's not going to cut out in the middle. And then, of course, you need the logistics and the infrastructure. So the staffing, the space, the floor plan to accommodate additional equipment. So I see that financial reimbursements are a major barrier. And as I've said, reimbursement for telemedicine, it would be hopeful if it would be equitable to in-person reimbursement. There's a lack of widely available integrated credentialing, especially across state lines, which is, I think, an impediment to the growth of virtual technology. There's, of course, the staff time and the increased demands on integrated care. A dedicated case manager is best practice for telemedicine, but may not always be an option for an OTP. One questions, could this be supported through better telemedicine reimbursement? And one also needs to ensure that make sure that the communication with the specialty pharmacy is accurate and adequate to ensure the timely delivery of medication and refills to the OTP sites. And of course, ongoing staff training and support. And so what I hope I've shown you is that I think that telemedicine for HCV management among opioid use disorder patients on methadone, at least in New York State, is a highly effective, and patients appreciate the convenience and prefer the virtual interactions over referral. And I think it may serve as a way to broaden the mission of the OTP. And I'd just like to thank all of the collaborators who've worked with this and funding from these entities. And thank you for the invitation to speak to you.
Thank you very much. That was great. I will start by kicking off the question of, could you tell us, what is in place and what is the PCORI grant doing? If you remove the PCORI grant, would this still be going on? Or?
That's an excellent question. So we are delivering clinical care in the context of a research study. So the reimbursements for the interaction are still are paid by third-party payers. 95% of patients in methadone programs in New York State have New York State Medicaid, which greatly supports this kind of endeavor, which I understand from state to state is different. And there are programs with which we're in the process of now rolling this out as a clinical endeavor. So in the Buffalo region, there are several programs that see this as a model that they would like to replicate. And we're also in discussions with New York State Office of Alcohol and Substance Abuse Services to implement this as a model, given the recent data that only 20% of, which is a recent survey, that only 20% of OTPs are actually treating on site. There's interest to incorporate this as a model for addressing this issue.
Perfect. Holly, you go first. Start with the H's.
Thank you. Holly Hagan, NYU. So you brought up the issue of differences in mission across the OTP versus telemedicine, providing hepatitis C care. And I wanted to follow up with you to ask you to talk about, cultural conflicts that could, in fact, impact patient care. And there's a couple of examples I thought of. One is that we all know that when people are in methadone treatment, oftentimes they're still using drugs. And so it may be in the interest of the telemedicine or other HCV care provider to provide harm reduction, to give people sterile syringes and so on. And that may cause a potential conflict. That's one. The other one is whether if a patient relapses and has a positive urine and then they're punished by the methadone program, how would that impact HCV care? So I'll let you just sort of talk about this specifically and broadly, if you don't mind.
Sure. So the programs that we're working with really have taken a patient-centered approach. So they're very tolerant and flexible with positive tox screens, and that is not a reason for discharge in many situations. So yes, if they miss a month of visits, and but there is, in each situation, there is a very patient-centered approach to addressing the substance use problem. And we've worked with a lot of the sites in order to integrate the telemedicine into that treatment care plan. So for example, and then I'll speak to the more broad, the specialty pharmacy repacks their Hep C meds. So they're in tear strips. So we can patients are on different take-home schedules. So some come once every 2 weeks, some come once every week, every day, including Sundays. So we've been able to so the nurses can tear off the number of strips to the number of pills to accompany their take-home medications. If patients are hospitalized, we've been able to give the Hep C meds because they're in the methadone program, and the methadone program knows that they're in the hospital, to have the medications delivered on site to the hospital so that they can continue them. We've been able to work even in certain situations. I mean, at least in somebody who was incarcerated, and so although although that was not one of the eligibility requirements, that's one of the discontinuation requirements for the study, we made sure to continue their medication. So we've been able to, or patients who go for detox, being able to schedule the visits when they're actually at the site. So though the flexibility, I think the flexibility of the telemedicine allows you to have flexibility with this patient population in many different ways. In terms of more broadly, and when patients do get into the ability, I mean, I think one of the expansions would be for, to be able to, which we're not pursuing, but would be, for example, this population is frequently incarcerated, being able to continue collaboration with jails and prisons so that they could continue, and certainly many prisons and jails, at least in New York State, have embraced the telemedicine concept.
I'm going to follow up to ask, so when you started, did you start by having these conversations about potential, conflicts between the two organizations? So how did you manage that? We're interested in sort of how, the program was adopted, how it was set up, and so that initial steps, how did you manage those?
So first of all, having, as was discussed previously, having the data from the pilot study was extremely helpful in order to say this can be done. Number one, the sites that have joined us really saw their mission to offer comprehensive care, and they struggled with, as we heard from the previous two speakers, how do I address this problem? How do I address the Hep C? In certain situations, providers in some of the blue circles that I showed you are not accepting referrals, or they require 3 months of abstinence when patients are referred to GI or ID practices. So not only is off-site referral ineffective because the patients don't go, but in some situations, providers aren't accepting patients, or require, or are expounding very onerous requirements like 3 months of abstinence, and if they relapse, then they have to start over to be seen. So we were able to basically integrate ourselves into that environment, which is happening anyway, and offer a solution. And I think that's where the site saw this as an opportunity to expand treatment for telemedicine. Another aspect has been the expansion of telemedicine and the ability to use. Some of the sites said, well, in south of Buffalo, there's still another hour of New York State, and some of the sites saw, at least at the time, there was no addiction providers in that area. So one of the sites in Buffalo specifically said, well, we would like to see it as part of our mission to expand treatment. We'd like to learn how to do telemedicine so that we can then offer it as a way to treat patients for, offer it for addiction. So that's another motivation for partnering with us.
Thanks. This is Hannah from Emory. So you have this kind of bird's eye view of, is it 12 OTPs, right? So I'm wondering, what are characteristics of those, any subset of those 12 programs where this integration has been particularly successful, and what are some characteristics of programs where it's been less successful? And then I'll have a follow-up question. I'll start there.
So I think that if I can rephrase the question slightly and say, what were the characteristics of the sites that decided to join? Okay, because I think, and I mentioned this at lunch, that this is, in many ways, you are building a relationship that with these sites that extends over 5 years. And we've recently passed the 2.5-year mark in the award. And it's been really one that has grown organically, I should say. And we see, and as I mentioned, I mean, I do have a bird's eye view, but we also do a lot of on-site visits. And we do HCV education at every site every year. And so that we maintain, because of the staff turnover, and to maintain those relationships. And we have staff breakfasts. We have staff appreciation. Some of the sites have staff appreciation. So there's been a whole host of interventions or that we've implemented in order to foster the engagement. So I think the sites that joined us and those that have embraced this were those that saw either their inability to treat Hep C as a problem, those that saw this as a way to expand their own reach, as I mentioned, in terms of offering other services that they might like to expand via telehealth. And in one situation, the administrator of the OTP is from Germany, and she said to me, I saw co-administration of medication with methadone in Germany in 2005. I've wondered why we couldn't do it in the United States. Why? And so that was I think, part of her motivation for joining. So in many ways, each site has its own story or its own champion. And that's what I said when I had at the beginning, you really need a local champion who's going to say, I'm going to take this on and this is my job or my responsibility.
Oh, that was great. Thank you so much. There must be, I'm assuming that there's heterogeneity in the success of this program across the 12 sites. Can you tell us about, characteristics of the programs where it's been particularly successful?
Yeah, the programs that have been particularly successful, and I should say that the ones that were not performing as successfully, we've worked a lot with to develop that. So I think that what really, there were staffing issues. So in other words, that we learned. So in other words, how many care managers per site, or how many days per week do you need somebody? Was one. The other was, how do we integrate, or how do we work within each structure, the structure within each site, to maximize our ability to engage patients, to talk to them, to have them come for their appointments. And really, it really takes a village, and you really need the buy-in for the whole program, which is why I mean, 3 or 4 weeks ago, we were in Syracuse, and we had a lunch, and we did an education for about 40 people. In the end of this month, we're going to our site in Newburgh, and we're doing an education there. And and so we've been on site at the sites from Beth Israel Mount Sinai several times. So it's a constant engagement and discussion with the sites in order to continue to foster the relationship.
So I'm going to follow up on that before the next question. It says, you said the sites that are successful. Can you define success? And you said those discussions in education, but are you providing sites with feedback on their performance?
Yes. Yeah. So the success is really the ability to recruit a certain number. I mean, in the context of the study, it's the ability to recruit a certain number of patients per period. And so we're using what we call the step wedge design as part of the study. So it's that ability is really the way that we measure success. And then in terms of outcomes, I'm not going to speak to them here, but just we are tracking how many patients we're following, and so each site first did the usual care, and then each site has done the telemedicine arm, and so we have those comparators. In terms of and so that's really the way in which we've been able to define success. But I also think it's the success of the staff or the engagement of the staff and the patients themselves. And we've developed a patient advisory committee, and we use those who've been through the program or others to continuously discuss and give feedback to what are some of the factors that make the interaction better, what are some of the factors that make it worse. And really, I mean, I think it's the acknowledgement of the work that goes into this, and the staff really appreciate the opportunity to be acknowledged by their leadership, by their directors, and by their administrators.
Thanks very much, Andy. A quick question, and then one that's probably a little harder. So far, everything you've been talking about with Hep C, any reason that HIV treatment couldn't? I just want to make sure. I think I know your answer, but.
I mean, to state publicly, I think that this is a model that could be used for, I mean, we're using Hep C in this situation as a test case, but I don't see any reason why expansion for addiction or for HIV or for other diseases couldn't be, provided you don't have to do a physical exam, couldn't be used. But I should clarify that we are working with the on-site providers, and so the on-site provider does a physical exam at each initial visit. So we do, to assess for cirrhosis, for ascites, for the concerns that one would have with a Hep C patient.
So they do vitals and one exam on site. The harder one is based on you've already been clear that critical to this is the willingness and enthusiasm of the opiate substitution site itself. And so I get that. When we try to think nationally of how to be more effective, did you learn anything about how opiate substitution therapy is governed to get insight into how we might or one might do this in states where there's no Andy Talal that's running around and making sure everybody does this kind of thing. So in other words, is there something about the way this works that where in order to provide, as a condition of getting your license to provide opiate substitution therapy, for example, or something like that, someone would have to agree to, if we ask doctors to have to integrate opiate substitution into theirs, then should we ask opiate substitution experts to have to integrate testing for HIV and Hep C and care in order to do opiate substitution? Or that might be a horrible idea because then we have fewer opiate substitutions. That's the last thing we really want. But that's a very open-ended question.
Sure, no, and thank you for the question. Yes, the regulation, the methadone dispensing varies from state to state. New York is, I think, perhaps more advantageous than others in the sense that it's provided by New York State Medicaid. At the time we started this program, there were 126 programs in the state, and that's only mushroomed because of the opioid epidemic. So in terms of the ability to have this, and I think, yes, it could be implemented in other types of substance use treatment programs. And one of the ones that we've been working with in Buffalo, if somebody comes in, I mean, the removal of the geographic barrier is a big plus. And in one situation, in a program with which we're in conversation, they have some people who, within the Buffalo area, so let's say in an hour travel radius, they come in for detox. They then are shift to another program where they're an inpatient. And then they're followed for a couple of months as an outpatient. If we think that most patients for Hep C can be treated within a 3-month period, saying from drawing blood, starting medication, and 2 months of treatment, that could be done within the 3-month period or the 90-day period that most patients are in detox. But if they have to come to a site for an on-site clinic, that ties up a lot of resources. But if one could follow them virtually from the detox to the inpatient to the outpatient, that makes a lot of sense, and see the same provider, then it doesn't matter where the patient is physically located. So I think, that's the kind of innovation that virtual healthcare can provide in this type of situation. And I don't see why it couldn't be implemented, and this is not methadone, this is buprenorphine, why it couldn't be implemented in other situations. To address your question about opioid providers, I think you're going to find a heterogeneous mix. And, and there will be, I'm not going to say, probably a quite large percentage that would be very interested in participating. And I know one site that wanted to desperately to participate in our study, but didn't have the requisite number of patients. That individual has actually, is now 2 years later, is treating on her own and got the training that she needed because she doesn't have, in this particular situation, there aren't providers to whom she can refer.
Okay, we got 5 minutes. So again, just remind everybody, quick questions, quick answers. Sandy?
Thank you. David asked some of, I think, what I was going to ask. Just before I go to that, some of the things you just said, I wanted to clarify before I ask my question. So you use the term detox. Are you saying, because we don't want people to detox, we want them to be on treatment. Do you mean they're not detoxing? You're not getting them off of treatment. You're actually trying to get them onto treatment.
Yeah.
Okay.
So inpatient, yeah.
So they're going to be on methadone.
Yeah,
okay.
Or buprenorphine.
Right.
Buprenorphine in this situation.
Right. Yeah. But in the program that you just discussed, the 12 sites, are they all methadone programs?
Yes.
Okay. And the segue to that was somewhat what David just asked, because as you know, there's very few methadone programs, and it's one of the rate limiting steps. Also, getting to something that Hannah had asked, so methadone being very structured, oriented, patients are used to going every day and everything. So there's a lot of differences potentially with buprenorphine on, home-based treatments, one day coming in, getting treatment, or extended release naltrexone, very different. Have you thought about lessons you've learned in how these, providing telemedicine to start hepatitis C treatment is very very structural program, and methadone could translate to widespread buprenorphine use, but also in the criminal justice, you said that was one of the reasons that it was ineligibility criteria, or they were removed from the study if they were incarcerated, given this population has a significant degree of involvement in the criminal justice system, utilizing what you've learned, lessons learned, into how to integrate or keep people in treatment, or start people in treatment when they get released, those kind of lessons. And so, yeah.
Sure. So first of all, I agree that methadone is very structured, and we've been able to leverage that for as a demonstration of the utility and effectiveness here. I don't, and those are the 12 programs throughout the state that are participating, yes, are all methadone programs, but I don't think there's any restriction why it couldn't also be applied to buprenorphine, and that's what we're actually working with some of the sites clinically to provide telemedicine for some of the buprenorphine sites in Buffalo. In terms of the criminal justice system and collaboration there, I also agree that would be an expansion. I mean, it's not something that we had thought about, but I think, 2.5, 3 years ago when we designed this, but going forward, it would be something that I think, lessons learned, yes, I would have continued with that. We recently had a situation where somebody was incarcerated in Rikers Island. They were already on treatment, but Rikers Island continued the treatment. And, we were able to make contact with them. And so that kind of collaboration exists.
Edward?
Have you looked at the financial impact of treating patients with hepatitis C, in that they're within a certain period of time? I think there's a figure that one person can affect a certain number of patients over that this would have a tremendous impact in terms of reducing the spread, especially in the prison system.
It is something that we're interested, but we have not done that in the current study, although it may be something, I mean, we will have the data, and it may be something we want to look at in the future.
Robin?
Two questions. One, when you think about national implementation 3 years from now, what are the two strategies you'll recommend? And second, you talked a lot about frontline engagement and patient engagement. And for those communities that have not engaged patients that way, what are two things you tell them to do?
In terms of national implementation, one, I think there are lessons learned, and the production of sort of an implementation manual is something that we would be helpful, and is something that we've considered. Related to that, I think that there are, and I would urge the committee to consider, there are things that don't require financial resources, such as integrated credentialing or credentialing across state lines for telemedicine, that could be very helpful for national expansion, and those are regulatory or convenience. The other would be, and to answer your second question about engagement of frontline staff and patients, I think the ability, the on-site visits and the ability to offer education and accompanied with a meal is something, but that's something that's very important. And it's the recognition of the staff that they are very important. And we also have quarterly, we have 2 patient representatives from each site. And we have a patient advisory committee that meets on a quarterly basis via video conferencing, 12 on a day. We do it over 2 days. And they provide feedback at their sites in terms of the recognition. And so I think that's something that could be very helpful in terms of expanding to sites that don't have patients or patient advocates frequently involved.
Well, thank you, Andrew. I think we're going to have to cut here. Appreciate your time. This is a very exciting program, and I think we're all looking forward to hearing more about how is it going and the implementations. And, you know, something that I think we as a committee need to really think about is what is the role of telemedicine as we try to expand this kind of integration going forward. So appreciate everybody's, you coming and presenting to us. We're going to take a 15-minute break, a little bit less because it's 2:47, and we'll promptly come back at 3 for our next presentation. Thank you. Our last presentation, and I want to thank Joyce Johnson, who has been patiently sitting here and hearing all the presentations. Hopefully that has been useful to you. Ms. Johnson is the clinical director of outpatient services and a nurse practitioner at a STEP Works Recovery Center in Kentucky, and she's presenting along with, is Melissa also here? Yeah. Okay, so Melissa, so not even via Zoom. Okay, so take it along, you know the drill. We want you to talk about, 15, 20 minutes about your program, and then just get in a conversation with us.
Okay, so STEP Works Recovery Centers is a private company. We're a small, technically for-profit business. We have 5 residential inpatient treatment centers that run 30-day treatment programs. We have a sober living environment currently with 4 apartments with a capacity of 16. We have an IOP program, and then we have my clinic, which is known as intensive health. So within the treatment centers, we have a PICC line program where our nurses maintain PICC lines for people that need IV antibiotics for longer than the hospitals are able to keep them. That's a really long story that I'm happy to discuss with you about why we do that, but I don't think that's really what you guys want to hear about. So, yes, absolutely we do. We take anybody you want to send to us. Yep.
So I would say that is something we'd like to hear about.
Okay.
Not just HIV and hepatitis.
You have all the ID providers.
Related,
all of a sudden we all went.
And we're trying to.
So our PICC line program started in 2015. It started originally as a collaboration with the University of Kentucky Medical Center. What they found was people would come in with endocarditis, abscesses, osteomyelitis, other serious bacterial infections. They'd need IV antibiotics for a period of 4 to 6 weeks through a PICC line. When people are actively using, you can't send them home with a PICC line. That's just not an appropriate thing to do. So these patients would end up taking up a hospital bed, and the hospital would not be reimbursed for that bed because there's no justification for that level of care. So the patient would stay in the hospital bed for 4 to 6 weeks. They would not receive any addiction treatment. They would only receive their IV antibiotics. And these patients would end up overdosing in their hospital beds, overdosing in the parking lot. One of the hospitals that we work with actually had an armed guard in their unit to prevent the dealers from coming onto the floor. We were there doing an assessment at one of our hospitals and actually intervened with Narcan when a patient we were doing an assessment on for admission started to overdose in front of us. So we started this PIC line program as a way for patients to receive early substance abuse treatment, receive their IV antibiotics in a safe environment, and then can continue on their healthcare path without having to come back to the hospital twice a day for peripheral sticks for IV antibiotics, without them lying in a hospital bed, the hospital losing money, the hospital having an increased overdose rate for these patients. And now we actually have agreements with the University of Kentucky Medical Center, the University of Louisville Hospital, Jewish Hospital in Louisville, St. Mary and Elizabeth Hospital in Louisville, and we've actually gotten other referrals from hospitals all over the state of Kentucky and one from North Carolina. So we do take people from that state. So that's a really interesting, innovative program that we have. We don't get paid extra for that, so that's just something that we provide and something that we do. The daily rate remains the same because the reimbursement rate is the same whether we provide those services or not. So we can come back to that later if you have more specific questions about the PIC line program. And then in my office, intensive health started out as a complex chronic medical disease model under a contract basis with our Medicaid MCO passport in the state of Kentucky. We found that a lot of people had significant complex chronic comorbidities and needed a higher level of care. So we entered into a contract with Passport to get a cap rate to provide as many services for these high utilizing patients as we could. Our goal in our office is to decrease the cost of the healthcare system and provide less fragmented care. So I actually provide as much care out of my office with these patients as I can. We provide primary care, behavioral health care. I started an outpatient MAP program in 2017, which has grown into a full service addiction medical home. We provide transportation for patients if they don't have it. So to our office, to their pharmacy, to a grocery store, to other specialist offices, we drive them to and from their homes to these places. One thing that I found in 2017 was that I had patients with hepatitis C that needed to get to Louisville because that was the only treatment provider. It's about 45 miles away. And patients couldn't get there because they didn't have transportation. So they might be able to make it there for the initial visit, but they couldn't make it there for follow-up visits. So they would then fail treatment because they couldn't continue treatment. I started treating hepatitis C in 2017. I went to my CEO and said, hey, I want to do this. Nobody else here in town is doing this, and I don't see why we can't. And he said, I don't see why we can't either. So write me a protocol and let's talk about it. Started treating at the end of 2017. At that time, the Medicaid MCO that we worked with had very strict requirements with who could receive hepatitis C treatment. You had to have a certain level of fibrosis. You had to be clean for a certain amount of time. Even with those requirements, we were able to treat 3 people. I lobbied with the pharmacy and benefit manager at the MCO to decrease those requirements. I was one of probably 100 people in the state of Kentucky that were doing that. And so they changed the requirements and now allow anybody to treat. But at the same time, they started paying more attention to who is treating and told me that because I'm not a hepatologist, I'm not a GI specialist, and I'm not an infectious disease specialist, that I could no longer treat hepatitis C. So I had 3 patients that had been cured. I had one that was in the middle of treatment at that time, and we couldn't get her the remainder of her treatment. So she actually failed treatment. So I took about 6 months to try to find somebody else that would collaborate with me to continue the hepatitis C treatment with our patients, and luckily found a provider in Louisville that was willing to do telehealth. So at this point, I do all of the workup. Our telehealth provider, Dr. Bennett Cecil, does a one-time consultation visit with the patient over telehealth and then mails me the medication, and I do all of the follow-up. Luckily, as of last Monday, our Medicaid MCO allowed me to become an independently credentialed hepatitis C provider. So now I don't have to have that collaboration with this specific insurance. I still do with the remainder. And that's pretty much the bulk of our infectious disease treatment. We do offer PrEP for HIV. However, we haven't really had anybody that needs it or that has accepted that from us. Most of the patients that we have that have hepatitis or HIV are already established with the Ryan White Clinic in Louisville. We've had two patients, I've had two patients that I've offered PrEP for, and they've both declined it, and then we're pretty quickly lost to follow-up at that point. We'll have patients go to the Ryan White Clinic, and then I'll take over maintenance of their medication and then refer back to that specialty if they need it. So that's about all I've got. Anybody
Terrific.
has questions? Oh, and I'm sorry, I totally left out a whole part of it. We are an addiction medicine practice. So there's myself, I'm a data waivered nurse practitioner with 100 patient capacity. And then I have another fellow NP in my office who also has a 100 capacity on her license. And we usually run pretty close to capacity on both of our licenses. We do provide long-term naltrexone injection. We've probably got about 50 patients that receive that. And then we also have a few patients that don't receive any MAT that still come to us for addiction-sensitive primary care. Over the addiction treatment centers, the residential facilities, we've got 4 psychiatrists who are board certified in addiction medicine. And among them, combined, they have about 60 years of addiction treatment altogether. Barriers that we find, so we are a small for-profit, we are a small for-profit practice. So we kind of live and die by our ability to provide economically effective services. Insurance reimbursements are declining, and because of our status as a for-profit company, we are not eligible for a lot of the grants and other funding sources that are available. So that is a huge barrier to us being able to expand our treatment offerings and to continue to provide care at the level that we do. For instance, we don't get reimbursed for treatment. That's considered, or transportation. That's considered a wraparound service that we provide through our cap rate. We don't get reimbursed for any peer support that we use. We don't get reimbursed extra for our PICC line program. So we provide some cutting edge treatment because it's the right thing to do, but it is very difficult for us to financially continue, providing those services. We also have a technology platform called Recovering Me. So I like to tell people that Recovering Me is kind of like Facebook for addiction with an education component. It connects social media and engagement along with education videos, little short 10-minute videos for basically for anybody, for people that have an addiction, people that have a family member or a loved one that's addicted. Our Recovering Me series is used by the Fayette County Drug Court System, and it's also used by Rikers Island. Not really sure why they chose us, but they did. And then we've launched a kind of a pilot program out of our office with using that as an engagement tool for our patients. Sometimes we'll assign that as homework. Sometimes we'll have a group and we all watch a video together, and then we talk about what that means for them in their own life and in their own addiction and in their own history. So as far as numbers go, we have 108 patients on the PICC line program that we've treated since January of 2018 with an average completion rate of 75%. We have, 7 patients have been cured in our hepatitis C treatment program so far. I have 6 that are actively in treatment and 30 that are pending treatment based on their length of sobriety or their insurance coverage or different things that are required to get them treatment.
Thank you. Well, as you saw, all of us who do ID jumped at the PICC line program just because we've heard about integration with hepatitis C and HIV, but increasingly a problem is people who come in with endocarditis and other infectious diseases, complications of opioid use disorder, who require long-term antibiotics, and they either stay in the hospital or they receive alternative therapy, and you put them in oral therapy or davolavansin or something that does not require a PICC line. So we're obviously really interested on your PICC line program as something that gets that integration happening, because again, I feel when I discharge somebody that I need to also treat their treatment, their addiction. Now you talk about being a for-profit company. Can you tell us just a little bit about your payer mix?
We are 95% Medicaid.
Okay.
So we are located about 40 miles south of Louisville, which means that our primary Medicaid MCO is Passport, which is the only not-for-profit Medicaid MCO in the state of Kentucky. We also have WellCare, Humana Care Source, Aetna Better Health, and Anthem are the other 4 Medicaid payers in the state of Kentucky. We probably have 2% Medicare and 3% commercial insurance, I would imagine, somewhere around there.
So Medicaid.
Mm-hmm.
Okay. Sandy?
So thank you. That was awesome, and thank you for all that you're doing. And so of the 108 that are on the PIC line, you're also administering with opiate use disorder?
So those are patients in our residential treatment center over the course of time since January of 2018. So yes, they do receive addiction treatment as well. It's the same type of care that anybody else in the residential treatment facility.
So you're co-administering with their antimicrobial treatment for their infection, buprenorphine predominantly?
We do buprenorphine quite a bit. We also have the opportunity to do Vivitrol or long-term naltrexone. And we also offer patients Nomad if that's what they're more inclined to do. So yeah,
And do you start that? You start the buprenorphine while they're hospitalized?
Yes.
And
yes.
so you're starting at the time of admission or identification that they have an opiate use disorder?
So the way the process works is the patient is obviously in the inpatient hospital facility. The hospital facility refers them to us. Likely they've already been detoxed to the point that they can have an induction with buprenorphine when they admit to the facility. So typically their buprenorphine is started immediately when they arrive with us. If they have been receiving, IV opiates for some kind of pain control, then they will still go through the same induction process as anybody else, which is usually within the first 2 to 3 days of being admitted to our facility.
That's great. And you then are the linkage to you are the community program. So you're the inpatient and the community program. So when they get discharged, are they going out to their homes with the PIC line, or are they staying inside the hospital the whole time?
No. So we have residential facilities. We're not actually a hospital facility. We just provide PIC line services within the residential facility. So they go from the hospital to our residential facility. Typically, by the time they complete their 30-day program with us, they're finished with their IV antibiotics and they're able to have their PIC line removed before discharge. And then they come to me. Often they'll go to our IOP program, and some of them will even move into our sober living environment. So we found that every change in hands with these people is a place that they can be dropped. So we've tried to expand our services to avoid as many drop points as possible. It still happens. People still go home and relapse and have a reinfection or a recurrence of their endocarditis. But it seems to be less if we're able to provide those addiction treatment services early on in their recovery.
That's great. Just a quick question. You said 75% or 75% completion rate. I'm wondering what happened to the other 25%.
The majority of them, well, all of them are either administratively discharged because they're not appropriate for our facility. That's very rare that happens. Usually that's some pretty severe mental illness, or diversion in the facility is an administrative discharge, unfortunately. A few of them leave against medical advice, so they elect to leave, and at that time, I provide after hours and weekend services for our PIC line program, and that's the majority of what I do. Is when patients decide to leave AMA, I get called in, I try to convince them to stay, and if they won't stay, then I take their PIC line out and refer them back to the treating hospital that they came from for continuation of those services. And then the third category of people that don't complete are a medical transfer. So we are not a hospital. We are a residential facility. We have nurses, but there are some things we just can't take care of medically in that environment. So we'll refer people out to the hospital, and sometimes they come back, and sometimes they come back with a PIC or without.
Thanks.
Yeah.
Thanks so much. I'm really impressed with such an innovative program, and I appreciate the context with Kentucky too. So, so I'm going to ask, you've heard us ask all the other programs about how they integrate harm reduction philosophy into their practice. So I'm going to ask you to sort of characterize your organization with respect to that abstinence to harm reduction continuum. And something you just said was, this, it seems like the PIC line program is going to bring in to your organization more patients who are not ready for treatment, shall we say. And so how is your organization sort of responded to sort of, has it led to new discussions about harm reduction? And I mean, just tell me how you're kind of grappling with what must feel like a bit of a cultural shift.
Well, to start with, harm reduction in my outpatient office, our closest syringe exchange program is the next county over. We're working with the Louisville Metro Syringe Exchange, which is actually how we got here. We are also working with our local county who's launching a syringe exchange program to see if we can be kind of a treatment provider for them when they launch their syringe exchange, provide counseling services and a referral to treatment for them. Inpatient in the facility, it's absolutely true that a lot of the PICC line patients that come in are not necessarily ready to be sober, and that's the majority of the patients that we see leaving against medical advice or doing some diversionary activities within the facility are those people that just aren't quite there yet. It's not uncommon for us to see those patients, if they discharge AMA, to come back to us either on an inpatient or an outpatient basis. So we have a lot of people that like us, and so even if they kind of fall off the map for a while, they'll come back to us eventually when they're ready to restart their recovery path.
Do you feel like the organizational culture is changing a bit though with the introduction of these patients who may have slightly different or just more exaggerated challenges with respect to abstinence?
No, not necessarily. Now, I don't do a ton of work in the residential facility. I mostly provide support for our medical directors when they're out with maternity leave or sick, and then with the PICC line program after hours. But what I've seen, the biggest shift in our residential facilities came when Medicaid started covering residential treatment. And so the majority of our patients changed from private pay and commercial insurance to Medicaid, and that's just a completely different population and a completely different approach to their own health care. You always have some risk of people that come to treatment because they're coerced by the family or by the criminal justice system, or by their healthcare providers at the hospital that they're at that maybe aren't quite in the right place for residential treatment. We have a thing called Casey's Law in Kentucky, which is where a family member can encourage the courts to mandate treatment for a family member, and that's at the financial cost of the person who's doing the referring. So when we get patients through with Casey's Law, you either find that they're very, very engaged because they don't want to go to jail, or they're absolutely not engaged at all and are just waiting their time out until they can kind of move through that criminal justice process. So, does that answer your question? Okay.
It feels like there's still some struggle in figuring out like what's the best way to provide care. I think that it's not just your challenge, it's everybody's challenge in terms of patients that want to leave AMA, that's still an area of.
It is a challenge. It is definitely a challenge. And honestly, the way that we approach that as a facility is try to pull somebody else in. That's why I get pulled in on the weekends when we have somebody with a PICC line that wants to leave AMA. I get pulled in to try to see if a different perspective or a different personality or a different way of approaching a patient can help them be encouraged to stay. A lot of times these people, when they come into our facility, they kind of get tagged with a certain person and they make a connection with that person. So occasionally we'll try to pull in different people just for anything to try to get patients to either follow the rules or be more open and forthcoming with what's going on with them in their lives and in their health care, or to stay residents in our facility. So.
My name's Ellen Eaton. I'm at UAB. Thank you for sharing. This has been really informative. I had a couple of questions. It sounds like there are some folks that don't qualify, but of those who do qualify for this residential transition, how many decline? The reason I ask is that I've recently read some work out of Portland where patients were offered this residential bridge from the inpatient to the community setting, and a large percentage actually declined.
I don't actually have those numbers. I can get them for you, though, if you'd like.
I was just curious if you had a general idea. I mean, is it your impression that most people...
I think most people that I'm aware of that get referred to our facility do end up coming to our facility. Now, how long they stay is a different matter, but I do think the majority of them end up coming through.
And a follow-up question, is homelessness a challenge? So we're at our hospital, I know it's hard to get folks into a residential outpatient treatment if they don't have a long-term plan. It's kind of viewed as like a bridge to nowhere, whether that's right or wrong. I've had trouble getting folks into that type of transitional placement with the PICC line, for example. And how do y'all handle that once people have graduated and their antibiotics are complete, for example?
So interestingly, the majority of our PICC line referrals come from a distance away, either from Louisville, which is about 40, 45 miles away, or Lexington, which is a couple hours away. So patients that are homeless, when they're in Lexington, when they're transplanted to Elizabethtown, which is where our PICC facility is, they start to develop that addiction recovery community with different people in the area that they become close to, and most of them stay. Most of them either transition into some kind of sober living, or they find somebody else in recovery that they can move in with and continue their recovery where we're at. I don't personally see a lot of people returning back to the environment that they were homeless and using in when they come from far away if they become established in our area. So, no problem. Of course, I also see an outpatient, so, you know.
All right, so when you started, you were talking about it really was a model you were trying to save money. And I'm interested in knowing, number one, did you? I assume because you transition people from inpatient stays to outpatient, that's an absolute yes. So things are going well in terms of the economics. And that was a yes, yes, okay. And the second was about the staffing model, because you have an inpatient responsibility, you have an outpatient responsibility, and you have a residential responsibility. So how do you staff? What does it look like, and how does it look different than some of the other organization of staff that you've heard about already today?
So the residential facilities and my outpatient office are separate. We don't have much. I'm really the only crossover blend between those two facilities. In the residential setting, they typically have nurses, RNs and LPNs who provide the medical care. We have peer support in the facilities. They also have therapists on site and our psychiatrist, as well as an administrator and those kinds of things. When patients come into the residential facility, they're taught how to clean and how to cook, and so they provide those services on their own. It helps to not only cut down on staffing costs, but it helps the patients who may not have those skills, those life skills that are so vital to a sober life, learn those skills and be more effective and efficient on their own when they're out in their own environment. Within my office, so as far as finances go, we have two real distinct programs running at the same time. We've got our CAP program with Passport, which is a complex chronic disease care model, providing as many services as we can under that umbrella. Alongside that, we have our addiction medical home, which actually takes any insurance and provides very, very similar services as intensive health, but under a different payment model. So our addiction medical home is a fee-for-service basis. Our intensive health model is a CAP payment where we get paid a flat rate per member per month that we're seeing those patients. And that's the one that we're really tracking cost to the healthcare system, utilization outside of our office, and things of that nature. So does that answer your question?
I think you answered the first question, was that you're not doing the screening for the opioid use disorder. They're coming from referrals from the hospital where someone's identified.
Sometimes.
Okay.
So, and as far as the PICC patients, you mean, or as far as anybody?
Yeah.
Yeah. So typically those patients are identified by their, yeah.
And then for women, do you have any specific women-focused interventions? Because as we know, women, the latest statistics are showing that women are dying from opiate overdoses at higher rates in the older age group. Well, I'll have to say I'm in that group now. In the 50 to, so middle-aged, 50 to 64. And we've noticed that there's a lack of services, and we know there's many barriers. And so when we think about a residential treatment program, many of whom are sole childcare providers and other things. Have you guys focused on how do you handle the women with PIC services and opiate addiction being in these residential programs?
So we have 2 gender-specific facilities. One is a female-only facility in Nicholasville, which is outside of Lexington. And then our London, Kentucky facility, which is kind of out in the middle of nowhere, is a male-only facility. Unfortunately, our PIC facility is a 3rd facility in Elizabethtown. So we don't have any adjustment for those PIC patients, but we do provide services specifically for women. And then in our outpatient practice, I will see anybody, pregnant women. We do opioid use disorder treatment in pregnant women. Obviously not Vivitrol, but we provide a lot of very specific services for women in the outpatient setting. We have a women's only group that meets every other week on Wednesday night. And then the rest of our meetings are gender mixed. We try to provide as sensitive care as we can for people that may have some trauma history. And our therapist is really, really good about kind of delving into that trauma history and identifying if people need services beyond what we're able to provide, in the hour that we have in the office with the patient.
Yeah, real quickly, back to this. You've already made it clear most of all your patients are Medicaid, so Kentucky Medicaid. Do the hospitals pay you also, or how do you make a profit taking care of Medicaid patients in a residential facility? Because usually that's not a highly profitable activity. I'm just curious.
No,
the
hospitals,
or is there something that?
I mean, we just provide, we really try very hard to provide economically efficient services. So our monthly rate is the same, and we just do our best to keep our heads above water. So, I mean, you say we're for profit, and technically that's true, but sometimes the profit is less than other times. It's really a balance between what can we provide and what is cost effective for us to provide. So that is a focus for us all the time, being so heavily engaged in what reimbursements are for Medicaid. Another issue with that then is buprenorphine limits. So that, as addiction medicine specialists, full-time addiction medicine providers, we have the same limits on our licensure as somebody that moonlights 2 days a week at a cash-only Suboxone clinic. And so that, my ability to see 100 patients at a time for addiction treatment really limits my ability to affect not only opioid use disorder, but also hepatitis C, because nobody's going to come to me for hep C treatment and somewhere else for addiction treatment if they know that I can do both. They're going to go find somebody that can do both if they can. So those buprenorphine limits really, really do make a huge impact on what I'm able to do and how many patients I'm able to affect. And they also drive some predatory clinical practices with urine drug screening. They provide some diversionary behavior with addicted people that are then selling their buprenorphine at a high rate to get cheaper drugs. And a lot of those would be solved by eliminating those buprenorphine limits, in my opinion.
So following up on that, if you were to have, a way to influence decision makers, HHS, what kind of advice would you tell them to improve it? What kind of policy barriers reduction are necessary to improve, to be able to better provide the services you're already providing?
Well, first of all, eliminating buprenorphine limits, obviously. I do think that some of the infectious disease treatment should be reimbursed individually. So providing the stick line services should have a separate reimbursable rate outside of a daily rate for a facility, but also increasing the amount of providers that can provide these services. As far as hepatitis C goes, it's pretty algorithmic for most patients. It's not really a very challenging thing to do, but insurance regulatory rules that require only certain types of providers or providers that jump through these hoops can treat really does limit the impact of a widespread treatment program. Insurance requirements that state a patient has to be clean for 6 months before they can receive hepatitis C treatment is a huge barrier. I personally don't have that big of a problem with the SAMHSA training that you have to get. 24 hours is a lot, but if you want to provide these services, it's worth it. And it's a good education base for what we do. So that's not really something that I personally take issue with, but I know other people in my field do take an issue with that. I think that a national prescription drug monitoring program would be a wonderful thing for us as providers instead of 50 different state-based or 49 different state-based programs. When patients go across state lines to fill medication, it really helps us to know what that is so we can avoid diversion, and they can do a lot of predatory and addictive behaviors with that kind of knowledge. So those would be my biggest: increase reimbursement rates, decrease buprenorphine limits, or eliminate buprenorphine limits, and decrease regulatory barriers to providing treatment. Did I answer your question?
You did. I think that following up on this, I'm curious as to looking at advising other groups similar to yours about what they need or what would be important for them to do what you're doing. What kind of advice would you have?
I would say the first thing you need is a clear idea of what you want to do, because if you don't have a very clear vision on what you're trying to accomplish, you can really get caught up in kind of following a rabbit hole that you don't intend to. Reading through the regulations and knowing what's required, knowing what you can do, what you can't do, and what's not regulated at all is important. I think having good support staff is absolutely necessary. If you don't have good people being the first engagement with your population, then you're going to have a hard time engaging people, no matter how good your providers and your service providers are. And I think getting in with somebody that knows what they're doing can help people to overcome the lack of confidence and the fear of what they're doing, and can also help promote a level of comfort with any kind of an intervention, whether it's addiction treatment or hepatitis C treatment or PICC line programs. I think having an expert on board just to call if you need them is vitally important.
Do you have a sense of unmet needs in your area? Patients who are on waiting lists, or patients who are trying to get in treatment but cannot?
Yes, we have a lot of different needs in our community. So we are in Kentucky. Kentucky notoriously is very low income, very education, I don't even know how to say it appropriately without being offensive. We need a lot in Kentucky. We need a lot of education. We need a lot of social support. There's no public transportation in our community. There is a lack of available treatment beds. There's a lack of high quality sober living environment beds available. So we have 16 beds. That doesn't even come close to touching the needs of the community. Insurance at this point with the Medicaid expansion isn't too much of a barrier, but if we were to lose that, that would be a very, very significant barrier. And then having corporations and factories and other employment opportunities available to people that can support them once they leave treatment is another huge factor.
So in general, you haven't reached a plateau in terms of the overdoses and unmet needs. It's still going up?
Yes, I think it's still going up. I haven't seen the most recent numbers. I think 2016 were the most recent numbers I've seen for our area, but at that point it was still going up, and I would expect that it's still going up.
Any other questions? Okay, well, we're going to say thank you. Appreciate you coming. Thank you for
Sorry I didn't have slides.
Thank you for sitting here all day. This was great.
No problem.
We appreciate not having slides. This was very good. Yeah, so what I'm going to do right now is, I'm going to ask if anybody has any follow-up questions. In particular, I want to ask people who may be on the web if they have questions.
Oh, Can I interrupt one more time?
Yes.
So I just got 3 text messages from my CFO, who is apparently watching online. He said, tell them your CFO is willing to talk with anyone specifically about the economics, especially the guy that just asked a question about profitability. Case management is a need, and tell them alcohol is the #1 substance of abuse. So.
We're with you on that. Yeah.
Sorry to interrupt.
Anybody else on the web who wants to send text messages to Joyce?
I'm open.
No, actually, if you have, I'm just joking. If you have questions on the web, you can send the questions directly to Andrew. His email is amerluzzi@nas.edu. And if you, I don't know if we have open line. If people can ask questions.
You can try that.
Do you see anybody online? Can you tell?
Yes, we have,
Well, one more time, I'll invite anybody on the web to send questions. And again, if you want to send questions or comments, you can always do it after the meeting. This is just the first meeting of this committee. We'll continue to meet, and please send emails and questions to the committee. The line is now open if anybody wants to ask a question. Okay, if there are no questions, I think we're going to move to adjourn this meeting. I want to thank all the invited speakers, and I want to thank all of you who joined the meeting through the web. I believe I speak to the entire committee when I say that we are eager to continue working on this, and we appreciate the time you had coming here and talking to us. If you have comments or questions, please, again, send them to Andrew Merluzzi. And his email, again, is amerluzzi@nas.edu. Please keep in mind that any material you wish to share with the committee will be made public through the public access file in compliance with Section 15 of the Federal Advisory Committee Act rules. So again, anything that you send will be made public. And with this, the meeting is adjourned. Yeah.